Thank you very much, Professor Grasso. I'd like to thank the organising committee of ECR for inviting me to speak today. It's a great honour to speak with such eminent speakers in the field of gastrointestinal imaging. So my talk today will focus on what the surgeon does, surgical procedures and normal post-operative anatomy. And the learning outcomes will be to discuss common surgical procedures performed in the esophagus, stomach, small bowel and colon, and to appreciate the normal appearances of an intestinal anastomosis on fluoroscopic and cross-sectional imaging, and finally to understand the normal appearances of hemostatic packing and other surgical devices on imaging. So imaging of the post-operative abdomen, as Professor Grasso said, poses numerous pitfalls for the interpreting radiologist. It is our role to try and differentiate an anastomotic leak versus a complex or unconventional anastomosis or reconstruction, to try and differentiate ileus versus small bowel obstruction. This can be difficult. To differentiate an acceptable amount of post-operative fluid or air versus a collection or abscess, and again this can be difficult, and also to differentiate unlabelled bowel versus collection or abscess. Also, there are new challenges which we have to face, such as finding and identifying surgical materials left behind intentionally by the surgeon, surgical packing and hemostatic compounds. Now here's an example of a case which posed some challenge to us. A patient who was post-operative and had a fever with an elevated white cell count, and we wondered about an abscess, and when we did the initial scan we could see here that there is something here anteriorly in the pelvis. We weren't sure was this an abscess or whatever, but what we did is we brought the patient back, and an hour later the contrast had moved on and more small bowel loops were filled. So clearly this was not a collection, it was an unlabelled bowel, and clearly that would have had a major impact on management. I just want to briefly talk about fluoroscopy post-operatively, and in this situation fluoroscopy still has a very important role. It provides real-time functional assessment. It can be limited by the patient's condition. Patients have difficulty moving, and also they have difficulty drinking oral contrast. I think it's very important that the radiologist is aware of drains. We must not pull them out, so you have to be careful of those drains from the time the person enters the fluoroscopic room. Be aware that the drains may cause the presence of intraperitoneal free air. Now, choosing contrast, we usually use water-soluble contrast and preferably non-ionic contrast. Gastrographin, as you know, can induce a significant chemical pneumonitis. We don't use barium much because we don't want barium spillage. Barium isn't easily reabsorbed, and it can cause artifact in the mediastinum or peritoneum on CT for many years. Water-soluble contrast has an advantage in this setting because it can be therapeutic for ileus or other small bowel problems. Now, this is a case who came into us at the Cork University Hospital, and it was a peculiar case. There was increased density surrounding the spleen, the liver, and the small bowel in the left lower quadrant. We were a bit perplexed by this, so we went back to the medical records, and there was a remote history of perforated sigmoid diverticulitis, and the patient had a barium enema at the time. So this is barium peritonitis, which had existed for many years afterwards. Now I'd like to move on to the esophagus. And esophageal surgery, as we all know, may be associated with significant morbidity and mortality. And one of the key things is that we must be aware and have a detailed understanding of the surgical resection and the GI reconstruction that the surgeon has done. Contrast studies are typically performed at 5 to 10 days prior to beginning oral intake or removing nasogastric tube or drains. Now, one of the key things for the radiologist is we must distend the esophagus, or else we're going to miss leaks. And it's also very, very important to assess GI transit beyond the anastomosis. These patients are prone to ileus, and these patients are prone to delayed gastric emptying. Non-ionic contrast is usually used, but sometimes we follow this with barium to get better definition, and some surgeons like us giving barium. Now I'm going to move through some of the common surgical procedures. Firstly, the Ivor-Lewis procedure is a common procedure performed. It's a two-stage procedure for mid-esophageal tumours. The first stage of the procedure is a midline laparotomy and then a right thoracotomy. So the laparotomy is performed to mobilise the lower esophagus and stomach. The duodenum is mobilised, and then a lymphadenectomy is performed if necessary. Then a right-sided thoracotomy is performed, the esophagus is mobilised, lymphadenectomy in the mediastinum is performed, and then you perform your esophagectomy with a wide margin. A gastric tube is made, and the anastomosis occurs at the level of the aortic arch. So this is what we see on barium. This is the native esophagus, this is the anastomosis, this is the gastric tube which we've formed, and a very nice result without evidence of a leak. Now, there are modifications of that, including the 3-stage esophagectomy or the Lewis-McKeown procedure. Now, really what that is just the same procedure, but with an added incision in the neck. And why do we do that? Because the surgeon wants to resect the esophagus more cranially. And also, you get a more extensive lymphadenectomy with that procedure. So basically, on imaging, you may find the suture line in the neck, but the key thing is that the anastomosis is higher up at the level of the neck. The transhiatal esophagectomy, we're all very aware of this. Thoracotomy is avoided, so that's a major advantage for patients with poor respiratory reserve and early-stage disease. So you have 2 incisions. You have a neck incision and an abdominal incision. In the abdominal incision, you mobilize the stomach, the esophagus, the distal thoracic esophagus, and then the second dissection in the neck, you dissect downwards and you dissect the esophagus from above. The esophagogastric anastomosis is performed in the neck, and the tube is delivered through the posterior mediastinum, as we see here. Now, one of the problems with the transhiatal esophagectomy compared to the other procedures is that extensive lymphadenectomy is less feasible. And the problem with that, of course, is that if you have extensive disease, you shouldn't be doing this procedure. Now, the left thoracoabdominal approach is a less common procedure. So in this case, you only have 1 incision, a left thoracotomy through the 6th or 7th intercostal space. It's usually done for lower esophageal tumours. Very similar in every other way. A gastric tube is formed following esophagectomy, and the anastomosis is formed at the level of the aortic arch. Now, esophageal bypass, these are interesting procedures, and sometimes usually performed with esophagectomy, but can be performed with advanced disease without esophageal resection. The conduits are usually made up of colon, as we have in this case, or jejunum, myocutaneous or fasciocutaneous flaps. The course of the conduit is variable. It can be substernal, it can be presternal, or posterior mediastinal in position. Substernal is the most common. Now, the key thing with these procedures is when complications occur, always remember there's been a lot of work and a lot of anastomosis beneath the diaphragm, so you have to be aware that you must also image the abdomen. So these are some examples of these seen on CT. This is a substernal colonic conduit, and these are 2 posterior mediastinal colonic conduits. Now, how do they look on imaging? This is a colonic conduit. High up in the neck, you have the anastomosis, and you have the normal haustrations. And here is a jejunal conduit with the normal valvulae conniventes. Now, I'll move on to more procedures for more benign conditions. Heller's myotomy, that's an interesting procedure done for severe cases of achalasia. Laparoscopic Heller's is now the most common procedure done. What the surgeon does, they cut the serosa, then they dissect the circular muscle, and then by the end of the procedure, the mucosa is pouting out very nicely through the incision. And one of the problems with this, when you disturb a circular muscle, you may predispose the patient to gastroesophageal reflux, and this is a low incidence of complications. Heller's myotomy, this is a very nice result with a Heller's myotomy here, very nice flow and no residual achalasia, and this is what you don't want to see, a small leak. I just want to move on to the stomach. There's been a lot of change in the last 10 to 15 years in gastric surgery. The range and subtypes of procedures performed have changed. There are changes in the incidence and location of gastric cancer, and there's more widespread acceptance of bariatric surgery. So Nissen's fundoplication now is very commonly performed laparoscopically, and basically what you do is a wrap is formed where the fundus is mobilized and the wrap is made anteriorly there, like there, the suture line is performed there. And this is what you see in the postoperative imaging, very nice example, and this causes augmentation and narrowing at the level of the gastroesophageal junction. This is another case of a fundoplication which we had. Again, the wrap is formed anteriorly, and you can see that there's augmentation of the lower esophageal sphincter. This is what it looks like on a CT scan, and you have a little leak here going back with a collection of barium in the left pleural space. Now, I'd like to move on to gastric resections. The Billroth 1 procedure is an old procedure, not performed very often. What you have is you have a distal gastric resection, and then you have anastomosis of the duodenum to the distal stomach. That's the Billroth 1. The Billroth 2 is very similar, except that you have a gastrojejunostomy, which restores the continuity of the gastrointestinal tract. Now, you do have a duodenal stump here, and it's important to remember that. Duodenal stumps can leak, and in that case, you need to perform CT scan for further evaluation. Now, subtotal gastrectomy with Roux-en-Y reconstruction. This is a similar procedure. Again, the stomach is resected, and the continuity of the GI tract is restored via a Roux-en-Y reconstruction. Now, total gastrectomy is usually for malignancy. The whole stomach is resected, and you do a lymphadenectomy if necessary. Again, you have a duodenal stump, and that's important. A Roux loop is brought up, as we have here, and anastomosis of the distal esophagus. The jejunal anastomosis is usually 50 to 60 centimetres from the esophago-jejunal anastomosis. Now, one of the key things for the radiologist here, when we're performing these procedures, we must get distension and we must move the patient into several positions, because you have to fill afferent loops and efferent loops, etc., and you won't be able to do that unless you move the patient and get good distension. And the other key point, I think, when you're looking at these procedures, if you're worried about a duodenal stump leak, you must do a CT scan. It's very difficult to diagnose this with barium studies. I want to move on briefly to bariatric surgery. And the two main types of bariatric surgery that we come across in practice are the restrictive type of surgery, which is the most common, but then there are also more complex combined restrictive and malabsorptive types of surgery. Now, the first type of restrictive surgery that you'll see is the vertical banded gastropexy, where a suture line, usually with a GI stapler, is made down along the stomach. It's parallel with the lesser curve of the stomach. So you create a very narrow gastric tube with a silicone band at the lower end. The silicone band is to cause further restriction. So on barium, this is what you see. This is the suture line here with the GIA stapler. This is the narrow tube, and you can see the silicone band is causing some restriction. And this is the excluded stomach, which regains its continuity with the stomach at the level of the gastric antrum. Sleeve gastrectomy, similar principle. You form a very narrow tube, but this time you resect the excluded stomach. So this is what it looks like, a very narrow stomach with duodenum beyond it. Now, what we see more and more in our practice in Cork are patients coming back after laparoscopic adjustable band surgery. And what that is, a laparoscopic procedure where a prosthetic device is placed in the proximal stomach just beyond the gastroesophageal junction, and there's a little pouch created above it. So the synthetic band there is joined then by a plastic tubing to a little port in the anterior abdominal wall, which allows us to adjust this device and cause greater or lesser degrees of constriction. So this is what we see on our imaging. This is the port, this is the tubing. In this case, we've injected some contrast to make sure that the synthetic band is still intact. And when we do barium studies, this is the esophagus, the stomach, this is the little pouch, and then you can see the restrictive band inferiorly. A case we had recently in Cork, a patient who had a laparoscopic procedure done, and you can see this is the band here, but the patient couldn't swallow anymore, had severe dysphagia from this. And you can see when we did the barium, we couldn't get the contrast by it. And then, of course, we had to adjust it under fluoroscopic guidance, and we got good flow of contrast into the stomach. Now, the combined restrictive and malabsorptive procedures are very, very interesting, very, very complex, and I won't have time to go through them in detail. The principles of it is that you have a restrictive procedure, a very narrow gastric tube, as you have here, a sleeve gastrectomy, which you have here, and then you also have a Roux-en-Y bypass, and the comparative lengths of the Roux-en-Y reconstruction determines the degree of the malabsorptive effect. So the lack of biliary and other enzymes for the majority of the flow causes a malabsorptive effect. Now, I'd like to move on to the small bowel and colon. Now, the small bowel is different to the upper GI tract in that we do contrast studies less frequently to assess for anastomotic leaks. CT and MRI are much more useful in this situation. Imaging is also performed to distinguish ileus from obstruction. That can be a very difficult distinction. CT is best for distinguishing complicated and uncomplicated cases of small bowel obstruction. Serial plane radiographs still have a role, and Dr. Dermot Malone and Mary Staunton from Dublin did an evidence-based review and concluded that a modified water-soluble follow-through can be very effective in this setting. If you give 100 mils of gastrographin orally and you perform a PFA at 4 hours, if the contrast doesn't reach the right colon within 4 hours, it's very suggestive of small bowel obstruction. So just to show you some cases here, patient here following small bowel obstruction, there's a suture line here in the right lower quadrant, a patient here with a stoma. And one of the key features here, I think, is that the small bowel doesn't really return to normal after these procedures. Many of them have Crohn's disease, as we have here. And you can see there's a lot of small bowel thickening, And it always looks abnormal, but the key thing is we have to look for obstruction, we have to look for fistula, and we have to look for abnormal fluid collections. The other thing is we're always looking for how well the stoma is working, as we see here. Now, this is a case where CT helped with a complicated cause of small bowel obstruction. Patient post-operatively developed severe pain, had this loop of bowel in the right upper quadrant. We were very concerned about the patient clinically, brought the patient to the CT scanner, and we could clearly see the same loop. There's a small bowel feces sign suggesting obstruction, and at the base of this, there's a twist at the base of the small bowel mesentery. There's lack of enhancement, so this patient we thought had ischemic small bowel due to a twist or an internal hernia, and you can see this is what the surgeons found. Now, I'd just like to finish with ilioanal anastomosis. This is performed following panproctocolectomy. It can be performed as a single, 2-stage or 3-stage procedure. The most common pouch is the J pouch, but you can see S pouches and W pouches. Fluoroscopy in these patients is usually performed at 2 to 3 months. And one of the key things you must do is do a good plain film beforehand to identify where the staple lines are. You can see them here so that you know what you're dealing with when you do the study. Now, these are some fluoroscopy studies on our patients. Here's a J pouch. Now, one thing you must look out for is this long J pouch appendage. If you don't appreciate that, you may think that the J pouch suture line has been affected or disrupted. The other thing, you could mistake this for a leak. Here's a very nice case, J pouch, nice volume. It looks absolutely like a rectum on the lateral view, so it's very impressive. CT can be very good for looking at the suture lines. We can see the suture lines very clearly here. And increasingly, we're using cine MRI for looking at the function of these pouches and also for looking for any problems with the proximal anastomosis. Now, the final surgical procedure I want to talk about are colectomy and various colonic resections. And we usually perform contrast enemas in these patients following surgery. Again, a control film is a good idea before you do the procedure. Anastomotic leaks, you have to be very, very careful when you're trying to diagnose these. You must do 3-plane views. A lot of these leaks are seen posteriorly, so you need a good lateral view. And this is typical examples here of a right hemicolectomy with a suture line. Another one here on a nice coronal CT. And this is a contrast enema, and you can see the anastomosis here very, very nicely. Another case here. Now, you have to be careful of the entheside anastomosis. You can see an entheside anastomosis. If you're not aware of that, you can mistake that for a leak. And this is how they look like on a CT scan, a nice coronal reconstruction, and then an axial view. It can be quite clear. So if you're not clear, call the surgeon, and they will put you straight, hopefully. Now, other contrast enemas post-operatively. This case we did, and we wondered, could there be a stricture? In that situation, we gave some Buscopan, and we can see it's clearly open. So it's worthwhile really looking at these carefully. And this is a case where we did a low anterior resection, a contrast enema, and there was this little outpouching here. We worried, was that a leak? But we turned the patient 360 degrees, gave a little bit of Buscopan, and you can see here that this was an entheside anastomosis. I wanted, for the last 2 or 3 minutes, I just want to talk about surgical materials left behind. Now, these can confound us and make our lives difficult when we're reading these cases. Surgicel is one of the things that we need to be aware of. It's usually a low attenuation mass in CT. Usually there's air interdigitating between it, and it can look like an abscess, and it's very, very difficult sometimes. One of the key things that it usually doesn't enhance, and the wall of it doesn't enhance, whereas an abscess usually does. Also on MR, Surgicel is hypointense on T2 weighted imaging compared to abscesses, which are nearly always T2 hyperintense. Now, this is a case from Damien Tolan, again, a very nice case in the pelvis with Surgicel. Again, there's no enhancement in the wall, but you can see the air. And another case from Damien in the left paraortic region. Again, a very nice example of Surgicel. This is just a case from Dr. Owen O'Connor, my colleague in Cork. And this is a new material which has been used by radiotherapists to displace structures away when they're giving radiotherapy, a substance called alloderm. This is a patient with cholangiocarcinoma, and they put this in the abdomen to displace the duodenum. You can see it here again. Now, if you weren't aware of that, I think you'd easily mistake this for recurrent tumour. So I think we need to be careful. We need to call the surgeons and see what the story is. The last thing is the imaging of meshes. The majority are polypropylene or polyfluoroethylene. There's sometimes you can only see the metallic studs, as we can see here, but sometimes you can see the whole mesh and the studs. And sometimes it's a little bit more difficult to see the mesh. This patient developed a hematoma following the procedure. The last thing is just procedures that radiologists leave behind and can cause confounders. I mean, this patient has not been shot. He's just been attacked by an interventional radiologist who's put coils in there for some bleeding. And the other thing is dropped gallstones. This case, we were worried for a while the patient had peritoneal carcinomatosis. It's not. It's a dropped gallstone. So in conclusion, ladies and gentlemen, there's no question that imaging of the postoperative abdomen is very challenging. I think the key thing is that we must know about the surgical resection. We must know what the surgeon has done to the patient to avoid misinterpreting these cases. It's very important, I think, that radiologists doing this are comfortable with barium and fluoroscopic procedures, and we correlate the information from both to make an appropriate interpretation of the patient's case. When you see peculiar things, consider foreign body or Surgicel, and it's important to try and differentiate those. And I think the key take-home message is we should never treat an image. We should discuss the case with the surgeon and correlate with clinical findings before a major decision is made. Thank you very much.
Thank you very much for the introduction. So it's a great chance to speak to you all about something I think is really challenging to all of us. So we're going to talk about the following areas as our objectives. So we're going to cover the imaging options for investigating suspected postoperative complications, the normal appearances after surgery and when to suspect a complication, and then the radiological appearances of postoperative complications and their interventional management. Now, unfortunately, in the interest of time, I could probably spend all day talking about this, but I think we've got to prioritise certain areas. And what I'm going to concentrate on is postoperative CT. Fluoroscopy and ultrasound are really important in managing postoperative patients, but I just want to talk about how we're going to optimise our CT scans, because CT is probably the main workhorse that we use. How to differentiate normal from abnormal on a CT scan in the postoperative period. How to recognise what surgeons leave behind by accident, and the top things that go wrong and what they look like. And first of all, we're going to talk about postoperative CT protocolling. Now, really, the key thing, I think, is that postoperative CT is very difficult, and you have to make it as easy for yourself as you can. So use your best scanner. Don't use the old single-slice scanner or the four-slice. You need the all-singing, all-dancing 64 or 128. And give contrast if you can, because that just makes differentiation of normal from abnormal much easier, as Mike has already shown us. And most importantly, get as much information as you can before you do the scan at all. Now, my inspiration for postoperative imaging is this guy, Dr. House. The reason why I think Dr. House is such a great guy is because he asks lots of good questions. And you may not know, but the inspiration for House is Sherlock Holmes. House, Holmes, similar sort of origin. But Sherlock Holmes always hunts for the truth, and he only eliminates a possibility or a diagnosis when it's logically proved impossible. So he keeps an open mind. And being open-minded is another really key attribute for postoperative imaging. Now, another thing I like about House is that he's very straight-talking, and he often says everybody lies, and that's no more true than in postoperative imaging. We often do not get the whole truth from the people that are referring us cases. And the things that we often get misinformed about are the wrong operation, the wrong post-operative time period. People will say they're 1 day post-op, they're 1 week post-op, and also the wrong clinical status of a patient. So they'll say that they're bleeding or septic, and they've actually got a slightly wrong interpretation of what's wrong with the patient. This is a classic thing that happens from time to time. You get told about a patient that is severely, profoundly septic, and they come down and they're sat in a wheelchair chatting to you, and they're not the way that they've been sold to you, which is what you imagine, perhaps with tubes coming out of all orifices. So how do we cope with this? Well, you have to use your powers of deduction, trust your eyes, and trust your knowledge. Particularly now that you understand all of these different areas of surgery that can be done in abdominal surgery, and ask the right questions. So the questions that I always ask to start with are, what operation did you do? What is your primary clinical diagnosis? What are you actually worried about with this patient? And how long ago did you operate? These are really essential. Now, when they say what kind of operation, you need to clarify, particularly if they use one of these named operations, because sometimes they'll use the wrong name, or they'll use a name when they actually did something slightly different from the standard procedure, particularly things like Hartmann's procedure. They may have actually done an anterior section where they joined the bowel together rather than giving the patient a stoma, for example. And in this situation, Napoleon had a good phrase: a good sketch is better than a long speech, particularly where the patient's had a really complex operation. Get the surgeon down and ask them to draw exactly what they did. And this is the reason why, because there's a huge amount of nuance in abdominal surgery. So the difference between a 2-stage and a 3-stage operation, you might vary how far up the thorax that you scan, and there are a multitude of pancreatic operations, and really you do need a sketch unless you are a real genuine expert in post-operative imaging to actually know what on earth is going on. Now, the reason why we need these sketches is because we need to know where the anastomosis is. We need to have an idea of what specific operation-related complications there might be. For example, in the pelvis, the patient might have had a ureteric injury. Have they made any modifications to the standard technique? And were there any particular difficulties during the operation, such as division of adhesions, or bleeding, or actually accidentally entering the bowel, causing an enterotomy? So once we have all this information, I want to know what is the key clinical concern. Are you worried that the patient is bleeding? Are you worried whether the patient's obstructed or has an ileus? Has the patient perhaps got a leak or is septic, or are they just not sure what's going on and they really don't know why, and they want a scan to try and work out why the patient's not recovering normally? And I use these categories to actually help me decide on which protocol to use. So the first protocol is a bleeding scan. This is an emergency scan. We do not have time to give the patient oral preparation, and the patient shouldn't have it because we're worried that the patient is actually bleeding. What we usually use is intravenous contrast injected quite fast, but beforehand to do a pre-contrast scan. The reason, so we're looking for these perhaps retained foreign bodies or things like that that we're not sure about, or to look for a hematoma. And then we'll use an arterial and a portal venous phase to look for contrast extravasation. Here's an example where we can see that a patient who's had bladder surgery, we can see contrast extravasation from the abdominal wall from an active bleeding point. If we move on from bleeding now to obstruction and ileus, we don't need positive oral contrast in these cases usually because the patient's bowel is dilated. The surgeons usually know that the bowel's dilated because the abdomen is very distended, or they've got an abdominal film that shows dilated bowel loops. And also, if you were the patient, you do not want to drink 1 litre of contrast when you're feeling nauseated already. Again, what we tend to do is just to give IV contrast in these patients routinely, and we image in the portal venous phase. We're going to go through some pictures of this in a few minutes. Now, in terms of sepsis or leak, I want to really concentrate on this and to get you to try and remember Autoroute 8, slightly unusual. Autoroute 8 is in a very nice part of France in the south. It connects Aix-en-Provence to Cannes. And the reason why I want you to remember this is because I want you to think about your route of contrast administration and to use 8% contrast. So Autoroute 8, what route and 8% contrast. So how much contrast should you give and what kind of delay should you give should you image after your contrast? It's really important that you fill your patient up properly with contrast if you're querying a leak on CT, okay? And how much contrast and the delay we're going to go through, and it's quite logical really. You want to test the anastomosis. That is the key. And we're going to use common sense about how much timing and how much contrast to give. So for the esophagus and stomach, these patients can just prep in the department. You can get them down for half an hour, give them maybe 500 mils of this 8% contrast, and then do the scan. And that will test the esophagus and stomach anastomosis. If we're talking about the small bowel, a proximal small bowel anastomosis, we need to give it a little bit longer and perhaps give the patient a little bit more contrast. So in this situation, we're going to maybe give them a litre and leave 60 minutes. So maybe prep these patients on the ward. But if we're looking more distally, maybe at the left colon or a distal small bowel anastomosis, we really want to give the patient a long delay, so 2 hours. If it's longer than 2 hours, that's just fine. And we can see here, this is a patient who's had a 2-hour delay, and we can see that they've got a leak from their anastomosis after a right hemicolectomy. Here's a patient that had pancreatic necrosectomy after acute pancreatitis, and the surgeon was not happy with the patient. They were septic. We gave the patient a 2-hour delay, and we can see the contrast here that's leaking from the transverse colon out into this big collection. So this isn't just necrotic pancreatic tissue, this is actually a colonic leak. So this patient had to go back to theatre to be defunctioned and have that abscess removed. When it comes to the rectum, you cannot really prep a patient's rectum from the oral end. You have to actually give rectal contrast. And again, 8% contrast. We tend to use about 500 mils, and how we actually deliver this is through a thin Foley catheter. Don't blow up the balloon, just put the catheter in the anal canal, and then use a bag and gravity just to let the contrast flow in across the anastomosis. So why do we bother giving rectal contrast? A lot of cross-sectional radiologists do not want to approach the rectum. That's one of the reasons why they gave up contrast studies. But in this situation, it's really important. So here's a case, patient with Crohn's disease who had a sigmoid colectomy. And looking at the CT scan, I can't really see very much going on that. We can see a surgical drain down in the pelvis. The patient's got a hand-sewn anastomosis, so we can't actually see where the anastomosis is. Unfortunately, after that scan that was reported as normal, the patient wasn't doing any better. They were still septic, taking a long time to recover. So this time, we gave the patient rectal contrast. And we can see really nice distension of the rectum, but now we can see that contrast has leaked outside the rectal lumen. We can also see contrast heading up along the surgical drain. And there we can see the contrast again. So the reason why you want to give rectal contrast is because it converts an impossible diagnosis into actually quite a straightforward diagnosis. And the only way to do that is actually to give the contrast rectally. The final group is the patient that the surgeon comes down and says, there's something not right with this patient. I really am not sure what's going on. These ones, again, I would give IV contrast to routinely. We'd want to give positive contrast, or you could sometimes give water, depending on what you think is going on. And then, again, rectal contrast if the patient's had pelvic surgery. So here's an example of a case. The patient's not right. They weren't really sure what's going on. This patient had ovarian surgery and debulking for cancer, and the patient had a laceration to their spleen that was undetected clinically at the time of operation. We can see active bleeding in this situation. This is just on a portal venous phase because the surgeons were not anticipating this complication. And here's another patient with poor urine output. We can see a reasonably well-distended bladder. I'm not showing you the hydronephrotic kidneys, but the reason why is because the catheter is inflated in the urethra. So deflate the balloon, put it in the bladder, patient's urine output miraculously returns to normal. So now we're going to talk a little bit about how to differentiate normal from abnormal in the post-surgical patient. And the things we're going to concentrate on are gas, fluid, and bowel distension. Now, in terms of gas, the important things to realise is that if a patient has laparoscopic surgery, they use carbon dioxide to insufflate the abdomen, and this is usually very rapidly reabsorbed. Usually everything is reabsorbed within about 2 days. So here's an example, a patient day 3 after a right hemicolectomy. There should not be any gas. There is far too much gas in this abdomen. There's also some fluid I'm worried that there is a leak. However, with open surgery, air is introduced into the abdomen. There's a lot of nitrogen in the air. This is very slowly reabsorbed. It can often take up to 10 days, sometimes longer than that. So it's not always that straightforward in these patients to work out what is normal from abnormal, particularly if there's a small volume of gas and the patient is quite a long time post-op. And it's particularly difficult if you're not testing the anastomosis for a leak with positive contrast. So again, to make life easier for yourself, if you think that there might be a perforation, use positive contrast. And you must remember this as well. It's very, very difficult for a surgeon to go back into an abdomen after day 7 because adhesions really start to form quite extensively after day 7. Before that, there's usually a window for a surgeon to go back in and check things out. So it's where we have to really prioritise these patients. And if the surgeons aren't happy, get them down soon rather than waiting on the ward for a few days for their CT scan. Here's an example, a patient day 10 after a gastrectomy. I'm not sure what's happened there. Oh, there we go. Day 10 post-gastrectomy. There's some gas here. What's going on? I'm not really very sure. This is a duodenal stump blowout with a leak. It's very difficult to diagnose, even on CT, but particularly on a contrast study. But what we're looking for is this abnormal pattern of gas. There's too much gas here for day 10. Now, if we have gas and we're not sure really what's going on, and you've not given the patient positive contrast, you always have the option of give them the contrast, send them back to the ward, and get them back again later in the day to repeat the scan to look for contrast leak. Another option is to scan the patient the next day and see whether the gas is increasing, particularly if the surgeons really aren't sure what's going on and they just want to watch the patient. The other option is if you see gas and you think there's too much and the surgeon's really not happy with the patient, they can take them back to theatre, particularly if it's before day 7. And then the other option is to offer to aspirate any fluid to see whether actually it's bowel content. That's another option that can help in some patients to work out what's going on. Now, fluid. Fluid is very difficult sometimes, particularly in patients who've got comorbidities like heart failure or portal hypertension. Remember that the amount of fluid that you would expect to see will change depending on what has actually happened to the patient during their operation. If they have a hernia repair, they should not have fluid in the abdomen, but if they've had a really complex, protracted operation with lots of adhesions divided, then you might expect to see more fluid. And also, you're probably going to expect to see fluid in a patient that's had an acute operation who's very unwell compared to a patient who's had an elective operation. So it really depends on the patient's status and history how much you might expect to see. There are some warning signs, though. Think about whether or not you expect to see any fluid at all. So here we've got a patient who's had a laparoscopic hernia repair. There should not be any fluid in the abdomen in this kind of patient. We can see the rivets to keep the mesh in place, and we've got this abnormal fluid around. Okay, there should not be fluid. This is a patient that had a colonic injury that wasn't detected at the time of surgery. Another clue when you're looking at the fluid is to look for peritoneal enhancement. If you see abnormal peritoneal enhancement like this, this tells you that this is not just ordinary fluid, this is almost certainly infected fluid. And also, certainly you wouldn't expect to see this volume of fluid in a normal patient. So this patient has peritonitis based on the CT scan. Another thing to look for about the fluid is to look for mixed density and for flecks of gas within it, because if you look for this difference in attenuation, it can either indicate a hematoma, but also potentially an abscess. So you're looking for this difference rather than just being simple fluid. These sort of complex features make you think this is an abscess. Again, if you're not sure, offer to aspirate. Here's a small collection just under the left lobe of the liver in a patient who had a partial gastrectomy. We couldn't opacify this bit with contrast, so we offered to pop a drain in, and out came pus. Next, abdominal distension. How do we differentiate what's normal from abnormal? Well, the key thing that we need to work out is the patient obstructed or is it an ileus? Generally speaking, with obstruction, we're looking for a transition point. In ileus, we're looking for generalized dilatation of the small bowel or the large bowel. But there are a couple of tips, because cases aren't always as straightforward as this one, where there are adhesions. Remember that if you have colonic distension, a transition point, particularly around the splenic flexure, does not mean that the patient's obstructed. You often get compression of the splenic flexure. This is just an ileus. Also, ileus can sometimes just affect the large bowel or just affect the small bowel, so don't misinterpret that necessarily for obstruction. Another very important area is to watch out for the mesenteries. If you have a patient in the early postoperative period who has dilatation and it looks like a closed loop obstruction, look for the mesenteries because this can indicate ischemia of the bowel loop. And also, you look for the double transition point. Generally speaking, you'll have collapse of the proximal bowel and then collapse of the distal bowel and the transition point here, but also look for these changes in the mesentery again. This patient needs to go straight back to theatre. They can't wait, as an ordinary small bowel obstruction might. So, how to recognise what surgeons leave behind by accident? These are never events. This should never happen, but it does happen sometimes, but they are rare. So look for the high-density marker that is in a surgical swab. This is not an anastomotic leak. This is not infected embolization coils. These are the markers related to a surgical swab. Often, these swabs can look very heterogeneous in the early stages after they've been placed. So again, you can see gas and fluid around it. But after, in a delayed phase, we can see that all you have left behind is the marker. You can't actually see the swab itself. So use MPRs, again, not to mistake this for anastomotic suture lines. And remember this case earlier? This is a swab that the surgeons left in deliberately because there was bleeding during the operation. They packed the pelvis, and this is just some bleeding because the packing was inadequate. So what are the top things that go wrong and what do they look like? We've just covered it. So the conclusion is postoperative CT is difficult. You need to hunt for the truth. Everybody lies. They don't do it deliberately, but they do lie sometimes. Get on the phone to your surgeon if you're not sure what's going on, particularly before you do the scan. Ask for a sketch, particularly if the operation is difficult. Make life easier for yourself by giving the right contrast. And remember, auto route 8, choose the correct route, use 8% contrast. Remember, sometimes surgeons will leave things behind by accident. It's our job to spot them because they do not realise that there's something left behind. And surgeons need us and we need surgeons. So pick up the phone because they are actually our friends and help them out. Thank you.
Thank you for the introduction. So my name is Alan. So I'm going to talk about postoperative abdominal and pelvic complications. So while this is not a comprehensive talk covering all complications, I will cover some of the more common ones. If I were to summarize the entire talk, I would say all complications involve bleeding, infection, and organ injury. We'll talk about some other surgery-specific complications. We'll start with colorectal surgery, although I would argue that a lot of these complications can be generalized to bowel resection in general. So here again are the complications: bleeding, infection. Some other things include anastomotic leak and small bowel obstruction. Here's our first case. Post-proctocolectomy presents with fever. We do notice throughout the abdomen there's these hyperdense fluid collections, some of them with fluid levels. We see that again on this coronal image. So this is a hemoperitoneum, so bleeding. Also in the same patient, there's this presacral collection of gas and fluid. So this is a presacral abscess. You'll also notice that there's a lot of soft tissue thickening and stranding in the anterior abdominal wall. There was purulent drainage on clinical exam, so this was also a surgical site infection. So this next patient, again, post-colectomy, presents with nausea and vomiting. And we do see pneumoperitoneum and a lot of fluid along the right abdomen. And if you carefully look at the suture line, there's the focal discontinuity right here where it enters this fluid. So this is an anastomotic leak secondary to suture dehiscence. This next patient is an ulcerative colitis patient. And when we look at her pelvis and look at the J pouch, we do see that the J pouch is thickened and inflamed. There's a lot of mucosal hyperenhancement and stranding around it. So this is a pouchitis. So pouchitis is a post-proctal colectomy complication in UC patients. The etiology is not fully understood, although it's thought to be related to disruption of the intestinal flora. Here are some of the CT findings, and we saw some of this in our case. Next, we'll move on to biliary complications. We'll talk about cholecystectomy, which has an open and a laparoscopic approach. The open approach typically has a lower complication rate because of a better field of view, although the laparoscopic approach is becoming preferred, or is preferred. Here are some of the complications, and we'll go over some of these. So this first patient is post-cholecystectomy presenting with pain and fever. And in the liver, we see these two lesions. So this first one looks like it's a walled-off multilocular complex collection. And then the second lesion, not really a wall, but there is this hyperdense tubular component. So I don't think anyone will argue if we said that this first collection is an abscess. But what about the second one? Sort of unclear, maybe just an unusual presentation of an abscess, although there is this hyperdense tubular component, like I mentioned, so thought to be vascular maybe. So this goes on to a CT angiogram, and here are the images. So again, here's that hyperdense tubular structure. And we do see a tiny feeding vessel right here from the hepatic artery. So this is a hepatic artery pseudoaneurysm. So next patient, again, cholecystectomy, presents with abdominal pain. We do see this large collection in the subhepatic region extending down the right paracolic gutter. In order to confirm whether this is a bile leak versus just some postoperative collection, this patient goes on to a HIDA scan. Here are the images. So as we go through, we see tracer start accumulating in the right upper quadrant right here. And upon further delay, the collection starts going down into the right paracolic gutter. So putting these images together, this is a bile leak. Moving on to the next topic, dropped gallstones. These result from injury to the gallbladder and spillage of its contents. It occurs more frequently in laparoscopic cases because of a smaller field of view. It's estimated to occur in up to 15 to 40% of cases, and in these cases, complete extraction of the gallstones is only possible in 1/2 to 2/3 of cases. A sister topic, the dropped clip. Incidence of this is unclear. Dropped clips are typically thought to be inert, so they're underreported. In one study that I found, comparing the two complications, they said that about just over half of the dropped stones developed into abscesses, whereas none of the dropped clips developed into abscesses. So here's our case. We immediately see this stone material along the posterior margin of the liver, and in an adjacent slice just above that, we do see this ill-defined fluid collection. So this is an abscess secondary to a dropped stone. Different patient, again, we see a dropped stone. This patient is presenting with abdominal pain and fever. When we look up a little bit higher in the gallbladder fossa, we see this large collection of gas, fluid, and some frothy material. So let's take a step back. We'll look at the operative note. The surgeon does note that they made a tear in the gallbladder and spilled some material, so that kind of explains our dropped stone. Reviewing further, they mentioned that they had some issues with bleeding, which they controlled with Surgicel material. So looking back at our image, this frothy appearance is a classic appearance for Surgicel material. So I guess the question is, are we happy because the operative note seems to explain all the CT findings? Well, no, because one, there's this air fluid level here which remains suspicious, and two, the patient is symptomatic. So this goes on to IR drainage, where they're found to have an infected postoperative hematoma. Next, we'll talk about the dropped clip, migrated clip. So the pathophysiology is poorly understood, but it's thought to be related to involution of the cystic duct stump, pulling the clip into the lumen, and as that tissue undergoes further necrosis, it becomes free in the lumen. So complications mimic those of choledocholithiasis. It can directly obstruct, or it may serve as a nidus for stone formation. That's what we're seeing here. So here's our patient with a remote history of cholecystectomy. In this case, we see 3 clips in the gallbladder fossa and an additional clip in the common duct. Here's the same patient from 4 years prior, where all 4 clips were seen in the gallbladder fossa at this time. No other clips were seen in this patient. So this is a migrated clip causing biliary colic. Next, we'll move on to bariatric cases. We'll focus mainly on gastric bypass. In these cases, knowledge of anatomy is very important. We should know the presence of the two anastomoses, the gastrojejunal and the jejunal, and we should be able to locate them on a rescan. Position of the rulum is also very important. Oral contrast may help in these cases for identifying these findings. So a little bit about the rulum. Can be anticolic or retrocolic. Here are some of the advantages and disadvantages. Just to highlight, the anticolic approach creates more tension on the GJ anastomosis, which is associated with an increased rate of leak and stomal stenosis. The retrocolic approach creates an additional mesenteric defect, specifically the mesocolic defect, and that has a risk of internal hernia. So here are some complications of gastric bypass. We'll look at some of these. So this first case is post-bypass 1 month ago, presents with abdominal pain, and we see here at the level of the jejunal anastomosis, there's this hyperdense collection. So this is a hematoma. This next patient, also presenting with abdominal pain, so immediately you see that there's gas and oral contrast around the liver and some contrast around the spleen. And if we follow this inferiorly, we see that this gas continues with the gastric lumen. So this is a good case for an anastomotic leak. This next patient is a history of known bleeding marginal ulcers. It's also noted in his history that he was recently placed on aspirin because of a cardiac procedure. So looking at these images, if you look along the superior margin of the stomach here, you see this apparent focal discontinuity, and you see a lot of stranding around this region. This patient was taken to the OR, where he was found to have a perforated marginal ulcer. So marginal ulcers are multifactorial in etiology. They typically respond well to medical therapy. They can be imaged with barium swallow, where you may see an ulceration at the gastrojejunal anastomosis. CT is preferred in the ER, although diagnosis is difficult because stranding may be your only finding. Oral contrast may help, but there's also the risk of false positives. Endoscopy can be performed for definitive diagnosis, although as in our patient, the patient may be directly taken to the OR. Here's the next patient, gastric bypass with diffuse abdominal pain. I'll highlight the rulum right here. And if you follow the rulum, you'll notice that, the rulum here gets pulled into the right lower quadrant. Coming back up, if you follow the ascending colon here, you'll see it enters the swirl and gets displaced to the midline right there. So this is an internal hernia with a swirl sign and displaced bowel loops. So internal hernia, the diagnosis is difficult to make. Here are some of the findings. You'll notice that some of them are kind of nonspecific. Displaced bowel loops can be seen in just a postoperative abdomen. Mesenteric twist you sometimes see, some edema, very nonspecific findings, which makes the diagnosis very difficult. Here are other cases of internal hernia. Again, abrupt cutoff of the SMV and a swirl sign. Here's another case. So this patient has an apparent mesenteric defect. You see small bowel loop vessels and fat getting pulled into this defect. And upstream to this, you see this dilated bowel loop. So it looks like the patient has an obstruction. This was called an internal hernia with upstream obstruction. The patient was taken to the OR. However, in this case, the surgeon noted that there was no internal hernia, and this was due to an adhesive band. So again, just highlighting how difficult these cases are. This next patient, again, presents with abdominal pain. In this case, we do see this dilated bowel loop, and within this bowel loop, you see another bowel loop, and then you see mesenteric fat and vessels being pulled inside. So this looks like a jejunal intussusception. This is a rare complication of gastric bypass. It typically occurs at or near the JJ anastomosis. Etiology is thought to be related to mesenteric thinning in the setting of weight loss or disruption of intestinal pacemakers. So to finish off the bariatric cases, look at a sleeve gastrectomy. This patient actually presented with shortness of breath initially. CTPA was performed where we saw this large collection in the left upper quadrant. This is a subsequent CT with oral contrast. And again, we see this large collection in the left upper quadrant. You do see this hyperdense material within the collection. This was the oral contrast just leaking into it. So this was a leak in the setting of sleeve gastrectomy. Next, we'll move on to some GU cases. So for prostatectomy, there are two approaches, intraperitoneal and extraperitoneal. The intraperitoneal approach is associated with a larger operating space and improved visibility, although there is a risk of bowel injury. Now the extraperitoneal approach has a more difficult access, resulting in longer operative times. although any hematoma or urine leak in this space is extraperitoneal. The same collection in the intraperitoneal cavity would cause bowel ileus and prolonged ileus. An additional advantage of the extraperitoneal approach is that there's no risk of bowel injury. Here are some of the complications. So here's our prostatectomy patient presenting with hip pain. A CT cystogram was performed, and at the level of the anastomosis, we do see this hyperdense material. This is contrast, which is extraluminal, so this is an anastomotic leak. Different patient, he presents to the ER with blood clots in the urine. They performed the CT after placing a Foley catheter and noting poor drainage. So immediately when you look in the bladder, you see the clots in the bladder, and then note the positioning of the Foley catheter, which explains the poor drainage. So they reposition the Foley and repeat the cystogram, and you will notice that there's contrast outlining bowel loops here. So then I'm just pointing at this in the supraumbilical region because it suggests that the operation was performed with an intraperitoneal approach, which explains why the contrast was in the peritoneal cavity. This was confirmed on the operative note. All right, next we'll move on to C-section. So complications include infection and bleeding. With regard to bleeding, hematomas tend to accumulate in one of two places, the subfascial hematoma and the bladder flap hematoma, which is between the lower uterine segment and the bladder. Here's our case. A C-section was performed 10 days ago, and we do see this hyperdense heterogeneous collection between the bladder and the lower uterine segment. So this is a bladder flap hematoma. Bladder flap hematomas are usually treated conservatively. However, if they're over 4 centimeters, we have to raise suspicion for a uterine dehiscence. Similarly, these little defects in the lower uterine segment, we see them with C-section, but again, because we have this large collection, this one measured about 9 centimeters, so we have to raise this suspicion for uterine dehiscence. Next, we'll talk about hernia. Here are some of the complications. Again, bleeding, infection, and bowel obstruction. So here's our first patient. He had a right inguinal hernia repair, and in these images, we see all this hyperdense material all along the inguinal canal extending into the scrotum. So this is a hematoma. This next patient had a ventral hernia repair, and we see a fluid collection in the operative site with a lot of overlying soft tissue thickening and stranding. So this is an abscess. So in this final case, we have these dilated bowel loops. On these sagittal and axial images, we do see a transition point at the level of the umbilical hernia repair site. So this is a small bowel obstruction. All right, so in summary, common surgical complications include bleeding, infection, and organ injury. Knowledge of events around surgery are important, so it's important to look at the operative note to see if there were any intra-op complications noted. Also, understanding the postoperative anatomy is essential, particularly in cases of bowel resection and gastric bypass. Thank you.
Hello everyone, I'm Dr. Linda Chu. I'm an assistant professor of radiology at Johns Hopkins, and today we'll talk about multi-detector CT of pancreatic surgery, differentiating normal post-op versus complications. So in this session, we're going to review some common surgical techniques for pancreatic tumor resection, review the normal post-op CT findings following pancreatic surgery, and review some early and late post-op complications following pancreatic surgery. So pancreatic surgery has evolved considerably since the earliest described pancreatectomies first performed in the late 1800s. Obviously, back then, the outcomes weren't very good. They didn't have clean surgical technique. They didn't have good anesthesia techniques, so lots of patients didn't do very well. All that changed in 1941 when Dr. Whipple reported a case series of pancreaticoduodenectomy for periampullary tumors, and patients did considerably better, but the mortality rate was still very high at 29%. Fast forward a couple decades, and now we have improved surgical techniques and postoperative management. The reported perioperative mortality for pancreatic surgery now ranges from only 1 to 3%. There are a few major types of oncologic pancreatic resections. The pancreaticoduodenectomy, or the Whipple resection, the central pancreatectomy, distal pancreatectomy, or distal pancreatectomy with en-bloc celiac axis resection. The pancreatical duodenectomy is more commonly known as the Whipple procedure, and is performed for periampullary neoplasms. It involves the resection of the pancreatic head, duodenum, a short segment of the jejunum, and the gastric antrum. A variation that can be performed is the pylorus-sparing version, which keeps the pylorus, and it in theory reduces the bile reflux, but this hasn't really been borne out in practice. So whether the surgeon chooses to perform the classic Whipple or the pylorus-sparing Whipple is really depending on the local institution and surgeon preference. So here's an image of what happens in a Whipple procedure. So it's an en-bloc resection of the pancreatic head and the duodenum. So to put everything back together, you need to perform a pancreatical duodenectomy, a hepatical jejunostomy, and a gastrojejunostomy. And here's the normal post-op anatomy, in which you have the pancreatic remnant going into the afferent jejunal limb. And here you have the hepatical jejunostomy with normal non-dilated bile ducts, and then here's the normal afferent jejunal loop. And then you have the gastrojejunostomy that is connected both the afferent limb, which receives the biliary input, and also the efferent limb. The central pancreatectomy involves resection of a part of the pancreatic neck or body. It's primarily performed in traumatic pancreatic transection and intractable chronic pancreatitis, and it can be used for small tumors with low malignant potential in the pancreatic neck or body. But this is usually not performed for pancreatic cancer because the lymphadenectomy is not considered adequate for an optimal cancer resection. And this schematic shows what happens in a central pancreatectomy, in which you have removed the central pancreatic neck or proximal body. The remnant pancreatic head, you have oversewn that stump, and then the distal tail needs to be connected to the stomach. And these surgeries are also performed less commonly because, as you can see, there are really two resection margins in the pancreas, and that can increase the chance of developing a pancreatic fistula. This is an example of a normal central pancreatectomy in which you can see that there's the normal looking pancreatic head, and then the pancreatic tail is now hooked up onto the stomach with a pancreatical gastrostomy, and you still have some dilatation of the pancreatic duct within the tail. The next type of surgery is a distal pancreatectomy, and is performed for tumors of the distal pancreas at or to the left of the SMV. It involves resection of the distal neck, body, and tail of the pancreas with en-bloc splenectomy. The cut edge of the pancreas is sutured to prevent a leak, and you can also perform a spleen-preserving variation, and you just perform the distal the distal pancreatectomy, but that would usually take a little bit longer. So this schematic shows what happens in the distal pancreatectomy, in which you cut open the pancreas here and oversew the free margin of the pancreas, and then you perform this en-bloc resection of the pancreas, distal pancreas, and the spleen. This is a normal post-op appearance following distal pancreatectomy, in which you have the clean resection margin here at the pancreatic tail, and the spleen is surgically absent. A variation of the distal pancreatectomy is the one with en-bloc celiac axis resection. This is also known as an Appleby procedure, and is usually performed in borderline resectable or locally advanced PDAC after neoadjuvant chemoradiation. It's a rather extensive surgery that involves resection of the distal pancreas and spleen, along with the common hepatic artery, celiac trunk, left gastric artery, and the splenic artery. So as you can see in this schematic, you cut the pancreas here and perform the distal pancreatectomy and splenectomy. But in addition, because the tumor is locally invasive and you have tumor spread along the vessels, you're also ligating the celiac axis. And then in these patients, you're really dependent on collateral flow through the SMA up the GDA to perfuse the rest of the hepatic artery and the liver. So this is a normal post-op anatomy after an Appleby procedure. And because there's so much extensive surgery that there's really most of the expected region of the pancreas is now filled with fat. And you can see the fairly normal looking pancreatic head here, and most of the surgical bed is filled with fat. And on the sagittal view, you can see that the celiac artery has been ligated. When I think about the types of post-op complications, we can divide them into early and late complications. And depending on what type of complication we're looking for, I would protocol the exam differently. In the early stage, a lot of the times when the patient is still in the hospital recovering from surgery, things that we worry about would be anastomotic leak, infection, hemorrhage, ischemia, and delayed gastric emptying. When the clinical concern is infection, we certainly want to give IV contrast, as that helps us see things a lot better. And if there's concern for anastomotic leak or delayed gastric emptying, PO contrast is very helpful. And PO contrast also can be helpful in these infection cases in differentiating bowel from fluid collection. In patients whose clinical concern is more hemorrhage and ischemia, you also would prefer to perform these exams with IV contrast, and sometimes doing dual phase would be helpful in identifying any vascular complications. And when patients are coming in later for surveillance, then the complications that we worry about would be development of anastomotic stricture and recurrence. And at our institution, for follow-up surveillance of these pancreatic cancer patients, we perform dedicated dual-phase CT for surveillance. In the leak or infection protocol, as I mentioned, CT with IV contrast is preferred because it improves the delineation of anatomic structures and it improves visualization of the pathology. PO contrast is helpful in differentiating bowel versus fluid collection, and it's helpful in demonstrating an enteric leak. In the normal post-op setting, a few days after surgery, it's expected to see minimal amount of soft tissue stranding or fluid in the surgical bed, such as this example here. You see a little bit of fluid after the patient had a Whipple resection. And you may see a little bit of induration around the mesenteric vessels. You may see a few prominent reactive lymph nodes. These I consider to be very expected normal post-op findings. And these findings come in a spectrum in which you can have just a small amount of free fluid, and then sometimes the fluid looks like it has a little bit of borders and start to have some shape, but not totally well defined. Those I would consider small amount of loculated fluid. And when the fluid has well-defined borders, I would call that a fluid collection. And usually when I read a case and say that there's a fluid collection, that's when IR would get called and then to drain the fluid collection. And obviously, if we have superimposition of gas or a thick enhancing rim, that would raise a concern for an abscess. The reported incidence of intra-abdominal abscess after Whipple ranges up to 6%. And the common causes include a pancreatic fistula, anastomotic leak, and superinfection of an acute post-op fluid collection. However, it can be difficult to differentiate an infected versus a sterile post-op fluid collection. If we see gas, then obviously that's very helpful, but just because we don't see internal gas within the collection, we can't really be sure that it's not infected. Some things that we have to be aware of is that sometimes fluid-filled bowel can mimic the appearance of a fluid collection, especially in cases of these Whipple procedures in which the afferent loop, because of the altered nerve supply and of the bowel loop, it generally is a little bit more distended, more fluid-filled than the rest of the bowel, and it may not fill with oral contrast, so it can mimic a fluid collection. I think the important clue is that we have to be very much aware of what kind of procedures the patient has had and what the expected normal post-op anatomy is. And we should look for signs of bowel folds, these bowel signature, and the fact that this so-called fluid collection is contiguous with the rest of the bowel, so we know that it's just part of a bowel loop and not a fluid collection. Another mimicker for fluid collection is fat necrosis or omental infarct. The pancreatectomy releases lipase from the pancreatic parenchyma that can result in fat necrosis. And the surgery itself can also disrupt the blood supply of the omentum, leading to omental infarct. And interestingly, these omental infarcts are more commonly seen with laparoscopic versus open distal pancreatectomy. This is a patient who had a distal pancreatectomy, in which in a 1-month post-op exam, you see small amount of fluid in the resection bed. And when you look up here in the left upper quadrant, you see that there's an area of fat and soft tissue attenuation. And this is from the omental infarct and fat necrosis. And when we follow this patient up 4 months post-op, you can see there's some involution, that this area has gotten smaller, and it's just a resolving omental infarct. And anytime we see a loculated fluid collection or air near the anastomosis, we should be concerned about a potential anastomotic leak. If we are very lucky, we may see focal discontinuity at the anastomosis. But we don't always see that, so we just have to keep our guard up, and if we see the fluid collection, we need to think about it. The types of anastomotic leak that we may see following pancreatic surgery depends on the exact type of the surgery. With any type of pancreatic surgery where we cut through the pancreas, it can develop a pancreatic fistula, or basically a pancreatic leak. With a Whipple resection, because there are the other anastomoses, we need to be concerned about a gastrojejunectomy leak or a hepatocojejunectomy leak. A pancreatic fistula refers to leakage from the pancreaticojejunectomy or the free resection margin from the distal pancreatectomy. It occurs in 10% to 29% of cases following pancreatic resection, and it has very high morbidity and mortality, with mortality as high as 35%. It is diagnosed clinically based on elevated amylase levels in the drain fluid on the 3rd post-op day or later. There have been some reported risk factors for development of pancreatic fistula, which include high BMI, excess abdominal fat, a small pancreatic duct, a soft pancreatic parenchyma when the surgeon palpates the pancreas during surgery, and also intraoperative bleeding. On CT, we may see a discontinuity at the pancreaticojejunectomy. We may see the localized fluid collection at the anastomosis, and we may see air bubbles near the anastomosis. But I think one of the more helpful signs is that if we have serial exams and we see progressively increasing fluid collection over serial exams, that would be concerning for a pancreatic leak. This is a patient who had an IPMN status post Whipple 3 weeks post-op, and here we see the pancreaticojejunectomy, and we see this air and fluid collection right at the PJ anastomosis. And we see some discontinuity here, so this is highly concerning for a PJ leak. This is the same patient, just shown in the coronal view, that we see this complex air and fluid collection right at the anastomosis. This is a different patient who had a pancreatic leak. The patient had a Whipple. and has clinically milky white drain output. And here we see the distal pancreas remnant, we see the pancreatic duct stent, and we see this kind of fluid cleft discontinuity at the PJ anastomosis consistent with the pancreatic fistula. This is a different patient who had a distal pancreatectomy post-op day 6, in which we just see a small amount of stranding and fluid at the resection bed, which I would consider pretty normal post-op appearance for major pancreatic surgery. However, on the follow-up post-op day 14 exam, we see that there's increased fluid along the resection margin, and this is consistent with a pancreatic leak. So, leak from the gastrojejunostomy or duodenostomy is very rare, with only about 0.4% following a Whipple. The CT findings, we may again expect to find a localized fluid collection adjacent to the enteric anastomosis. And I think this is where giving oral contrast makes the diagnosis much easier, because we would expect to see free extravasation of the oral contrast material. This is a patient who had a PNET status post extensive surgery, including a distal pancreatectomy, splenectomy, gastrectomy, and has an esophageal jejunostomy. Patient was not doing well and had a high white count and was septic. And when we gave the oral contrast, we can see that the contrast has made it through the small bowel. But if we look closer, we see that there's this irregular contrast collection in the left upper quadrant. And this is because there's a breakdown at the esophageal jejunostomy. And another potential site of leak is at the biliary anastomosis. And leak from the hepatojejunostomy or choledochojejunostomy is also very uncommon, with a reported incidence of 3.7% following a Whipple. The major risk factor is preoperative radiation therapy, and the imaging findings, again, are usually a localized fluid collection adjacent to the biliary anastomosis. And if we are suspicious about a biliary anastomosis, this can be further confirmed with an MRI using a hepatobiliary agent or with a HIDA scan. And we'll take a break, and then we'll go through part 2 of the post-op complications.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctassist.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi everyone, welcome back. I'm Dr. Linda Chu, and we're going to continue our discussion on multi-detector CT of pancreatic surgery, differentiating normal post-op versus complications. In the previous segment, we have talked about some of the early post-op complications, including anastomotic leak and infection. And for this segment, we're going to go over the rest of them, starting with hemorrhage. Hemorrhage is seen in less than 10% of patients following pancreatectomy, but it accounts for up to 38% of mortality. It can be broken down into either early hemorrhage or late hemorrhage. Early hemorrhage in a Whipple patient is usually due to GDA stump insufficiency or technical failure of the surgery. If it occurs more than 24 hours later, usually it's due to development of an ulcer, some pathology that erodes a vasculature, development of a pseudoaneurysm, or anastomotic dehiscence. And when you want to evaluate hemorrhage, there's a variety of CT protocols you can potentially do. If all you care about is to look for a hyperdense fluid collection or hematoma, frankly, you can do it with any of the protocols. Either you can give IV contrast or no contrast. You can see it in all of them. If your concern is potential GI bleed, I would strongly say that you should not give any positive oral contrast, as the presence of positive oral contrast will mask any active bleeding into the GI lumen. And if you want to look for active contrast extravasation, then you need to do a dual phase. And here with our protocol, we do an arterial and venous phase exam. None of the other protocols will allow you to tell that there's active contrast extravasation. And sometimes surgical materials are inherently radiodense, and to differentiate a bleed from surgical material, dual phase is also very helpful, and sometimes in the non-contrast it can also be more obvious. So in looking at hemorrhage, you're really looking for a hyperattenuating fluid collection, and depending on the protocol that you have selected, you may or may not be able to identify active contrast extravasation. As I mentioned, the main thing is if you are thinking about potential GI bleed, do not give any positive oral contrast. And I do find that sometimes these bleeds can be rather subtle on the axial images, and multiplanar reconstruction and MIPS can be very helpful in subtle cases. And not everything that's hyperdense is due to hemorrhage, and some other materials such as surgical material or medication can also be hyperdense. This is a patient who had a Whipple on the post-op day 3, and even when you look at this case, you can see that there's a lot of very heterogeneous material throughout the stomach. And when you compare the arterial versus the venous phase images, you see this blush of contrast that increases from the arterial to the venous phase images, consistent with active contrast extravasation. And this is the same patient. Now I'm just showing it on MIP images, and you can see that you can see that blush of irregular contrast that is within the stomach lumen. But I think the MIPS can sometimes be helpful in differentiating this surgical material, that you can very clearly see that those hyperdense material are due to suture lines. And this is a different patient who had a Whipple 6 weeks ago, who comes in with intermittent GI bleed. And you can see that this is the pancreatic remnant, this is the afferent jejunal loop, and when you look, there is this abnormal contrast collection there, and surrounded by a hematoma. And you can also see that abnormal contrast collection on the coronal view. And this is due to a GDA pseudoaneurysm. And sometimes these pseudoaneurysms can be rather subtle on the source images, and these 3D reconstructions can help. In the normal expected post-Whipple patient, you have the common hepatic artery coming through, and they should really clip off the GDA right up against the common hepatic artery margin, and there really shouldn't be much of a remnant. So if you see an abnormal collection that's sticking out at where the GDA used to be very concerned about a GDA pseudoaneurysm. This is another patient who had a Whipple, intermittent GI bleed, and it's also due to a GDA pseudoaneurysm. And these pseudoaneurysms can be very subtle, such as this case is only about 2 to 3 millimeters big, that you can see on the axial. You can kind of appreciate it on the coronal. Again, you have this abnormal outpouching at the location of where the GDA used to be. And when you look at it on the MIPS, you can see that a little bit better. And hemorrhage can be also due to a pre-existing pancreatic leak, because the pancreatic juices are very erosive and they can break down the vasculature. So this person had a distal pancreatectomy with known pancreatic leak, and then now the pancreatic juices have eroded through some of the vessels and now has caused active bleeding along the greater curvature of the stomach. Another dreaded complication of pancreatic surgery is ischemia. So again, depending on how sick the patient is and clinically how they're doing, people may choose different protocols. But I would say if they are really concerned about ischemia, dual phase would be my protocol of choice because we can look at vascular patency, we can see those better than on a single phase exam. We can look at organ enhancement, and we can also see secondary signs of ischemia. But if the patient has really bad renal function or the clinician really just don't want us to give contrast, then we become very limited in that we can't identify vascular patency, we can't tell if the organs are enhancing normally, and we really need to just rely on secondary signs of ischemia. When we think about causes of ischemia, it can be due to arterial thrombosis, venous thrombosis, or even if all the vessels are patent, it can be a global low flow state, and that's referred to as non-occlusive mesenteric ischemia. And the CT findings, depending on whether there's a vascular thrombosis, we may or may not see that, but we'll see other signs of ischemia, including altered organ perfusion, organ edema, pneumatosis, and portovenous gas. This is a patient who had an ampullary cancer status post-Whipple with abnormal LFTs, and you can see this very abnormal enhancement in the liver. And when we look at why, and when we look at the pre-op CTA, the patient had severe celiac artery stenosis. So just remember, when you do the Whipple procedure, you are taking down the GDA. And in this particular patient, because of the critical celiac artery stenosis, he or she is really dependent on this GDA to supply the hepatic artery. So once you have taken that down, patient is susceptible to liver ischemia. A similar patient here, a patient who had a Whipple, had abnormal LFTs. So again, when you look back at why, the patient had median arcuate ligament syndrome. So that means that he is also dependent on supply through the GDA. This is a different patient who had a venous ischemia, patient who had a Whipple, complicated by acute SMV thrombosis, as shown here. And you can see that there's marked bowel wall thickening of the small bowel and colon due to venous congestion. This is another patient who had a Whipple with portal vein reconstruction, however had acute portal vein and splenic vein thrombosis and resulted in a splenic infarct. And just to show you an example of non-occlusive mesenteric ischemia, this is a patient who was after cardiac arrest, and you'll see very characteristically very hyper-enhancing adrenals and small bowel. Another common postoperative morbidity following Whipple resection or other pancreatic surgery is delayed gastric emptying, and that can affect up to 40% of the patients. It is due to localized disturbance of autonomic innervation of the stomach near the operative bed. Patients usually have persistent nausea, vomiting, or need for NG tube decompression. On CT, we will see a markedly dilated stomach, and we need to look very carefully to exclude an anastomotic stricture or recurrence. This is a patient who had PDAC status post-Whipple, post-op day 7, and this is an upper GI small bowel follow-through, and you can see that this is the immediate overhead. We can see that practically all of the contrast sits in the stomach with very little going into the efferent loop. And this is a 75-minute delay. We see most of the contrast is still held up in the stomach. And this is the 210-minute delay. We still have a lot of contrast sitting in the stomach, consistent with delayed gastric emptying. This is a different patient who had a Whipple 14 months post-op. And again, we have marked gastric distension with oral contrast material. So we have reviewed some of these early postoperative complications that usually occur while the patient is still in the hospital. And now we'll switch gears and talk about some of the later postoperative complications, including anastomotic stricture and recurrence. The incidence of anastomotic stricture after Whipple at 5 years is fairly low, about 8% at the hepaticojejunostomy and 5% at the pancreaticojejunostomy. But anytime we see a post-op anastomotic stricture, we need to look at the anastomosis very carefully to exclude recurrence as the cause of a stricture. Local recurrence in the remnant pancreas or local regional structures occurs in up to 30% of the patients. The presence of a positive margin increases the risk of local recurrence, and when you only have one exam, it can be very difficult to differentiate recurrence from expected postoperative changes. So comparison with baseline post-op exams and serial exams is very helpful. CT findings that are worrisome for recurrence would be increased soft tissue in the surgical bed. And usually this soft tissue I find has a little bit more enhancement, a little bit more rounded or convex borders compared to just the post-op findings, which tend to be more ill-defined and strandy rather than soft tissue. And we may also see increased mass effect on the vessels with more vascular encasement or narrowing. And we may see new anastomotic stricture at either the PJ or the HJ. And these are sites of local recurrence. Other common sites of recurrence for pancreatic cancer patients would be in the liver and within the peritoneum. The post-op changes, the soft tissue should remain either stable or gradually decrease over time. This is an example of a patient who had a distal pancreatectomy. And when you look at this 7-month post-op exam, you still see some soft tissue at the resection bed. If you just have one exam, it can be rather difficult to tell if this is just expected post-op change or if there's some residual or recurrent disease. But here I can show you the same patient 4 years later, that amount of soft tissue has decreased over time, so we can tell that that's just normal post-op changes. And it's particularly important when more and more of our patients undergo neoadjuvant chemoradiation before surgery. So this is the patient at baseline. You have this locally advanced cancer, and this is the patient after chemoradiation. And you still see this ill-defined collar of soft tissue around the SMA. And this is the 1-month post-op, and you see a little bit of soft tissue near the SMA. Given that the patient had negative resection margins at surgery, this soft tissue is likely due to just normal postoperative findings, but we'll need to follow up to tell whether this is post-op changes or if there could be recurrent disease. And just to show you some examples of proven recurrence so that you can see what that looks like, this is a patient who had an Appleby procedure. This is the 1-month post-op exam. This is the ligated celiac artery, and you see just a small amount of ill-defined soft tissue in the pancreatic resection bed. Hard to tell if that's just post-op or recurrent disease. But when you look at the 6-month follow-up exam, you can see that there's increased soft tissue in the resection bed. And then when you look in the 18 months follow-up, it's even more obvious, and now you have lost the fat plane with the SMA. This is another patient who had later on recurrent disease. So this is the first initial 1-month post-op exam after Whipple. I would say it looks pretty good. Everything looks pretty clean. And this is the HJ here. So minimal soft tissue at the resection bed. So things look pretty good. Unfortunately for the patient, on the 7-month post-op exam, you see that there's more soft tissue centered at the hepatocujegnostomy, more biliary dilatation compared to the baseline exam, and this is due to recurrence at the HJ. This other patient had recurrence at the gastrojejunectomy, in which you would notice that there's moderate dilatation of the afferent loop, and when you trace the afferent loop to the anastomosis with the stomach, you see that there's this enhancing soft tissue mass right along the suture line. And this is causing some degree of obstruction, causing afferent loop syndrome. Other sites of common recurrence for pancreatic cancer patients would be in the liver. This is a patient who had a Whipple and resection of a solitary liver lesion, and on the 6-month post-op exam, there are numerous new liver masses consistent with metastatic disease. And the third site that we need to look very carefully is along the peritoneum. The same patient that I just showed you on the 6 months post-op has a very small amount of soft tissue thickening and stranding along the peritoneum. It may be hard to tell at this point, but then a few months later, it's a lot more obvious where you see discrete nodules along the peritoneal cavity, consistent with peritoneal carcinomatosis. And the tricky thing with carcinomatosis is that not all peritoneal nodules represent peritoneal carcinomatosis. This is a different patient who had a distal pancreatectomy 1.5 years post-op, and we see that there's this soft tissue nodule in the left upper quadrant. Patient even got a PET to show that it was not FDG avid, and this was just a splenule after patient had distal pancreatectomy and splenectomy. Another mimicker would be fat necrosis. This patient had a Whipple 3 years post-op, and we see that there's this soft tissue nodule within the omentum. And when you look closer, you can see that there's some internal fat density within this soft tissue nodule. So it looks a little bit different from the other cases of peritoneal carcinomatosis. And when we look back further in time, at the 1 month post-op exam, we noticed that this was a large area of omental infarct. So this was just an involuting fat necrosis over time. So within these past 2 talks, we have gone through some early and late postoperative complications following pancreatic surgery, and I hope that I have provided some representative examples and some tips on differentiating some post-op complications versus normal post-op. In conclusion, CT is the modality of choice in detecting post-op complications following pancreatectomy, and awareness of the normal post-op anatomy and CT findings are key for detection of post-op complications. And thank you very much for watching. I'll see you next time.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctassist.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
We're going to get started. We have 4 speakers this morning, and we will take questions at the end if we have time. So I'm going to begin. My name is Sherry Cannon. I'm from the University of Alabama at Birmingham, and I'm going to be talking about the upper GI tract. All right, so specifically today, we're going to limit our discussion because of the time limit just to talk about fluoroscopy. I think it's probably the area that has the most potential for misadventures, so we're going to limit it to fluoroscopy. And again, of the upper GI tract, we're going to talk a little bit about how to safely prescribe contrast agents in these patients. We're going to specifically review some of the postoperative anatomy. I think this is key because these studies really are not protocol driven. We have to answer 2 questions definitively. Is there a leak and is there obstruction? And that is our goal. And if we are unable to do that, 2 questions definitively. Is there a leak and is there obstruction? And that is our goal. And if we are unable to do that in our reports, we have really failed our surgeons. To be able to do that, you need to understand the anatomy because you need to know where to direct your images for leaks. We need to be able to recognize these complications. And also importantly, we need to avoid fluoroscopic pitfalls. So the most important thing I'm going to tell you today is this: clean up afterwards. And I don't mean that in the sense of clean up the room, although your technologist would probably appreciate that. I mean, when you have a patient like this, in this case, it's too tight of a lap band. There is a lot of residual contrast in the dilated pouch. If these patients are obtunded, particularly if they're obese, And if they're on a stretcher, you don't want to send them back to the floor with a full gastric pouch or a full esophagus. You really need to place a tube and drain this before you send them back to the floor. These patients are at high risk for aspiration, high volume aspiration, and it's a very difficult resuscitation. So we need to make sure that we don't leave our patients like this. So we're going to talk about a few principles of fluoroscopy because regardless of the surgery, these really apply across the board. The first one is, again, understand the surgical anatomy, and I can't stress that enough. This is not a procedure where you walk in the room and wing it. You need to know the specific anatomy. In fact, when I work with residents, I make them draw out the anatomy before they go into the room and point to me where the patient will leak from. I think that's important. We need to screen these patients just like we do when they roll into CT to get intravenous contrast. Most of these studies are going to be water-soluble contrast. They have the same risk profile as the intravenous contrast agents. We know that small volumes of these agents are resorbed across the GI mucosa. We know this is increased in post-operative patients, and we know that anaphylactoid reactions are not volume dependent, so these patients need to be screened. Really, each patient needs a scout image, and we'll talk more about this in a moment. And I recommend recording these as well. Sometimes you're able to capture information and you can go back and view the video recordings. I think this is very important because sometimes you get one specific moment, and if you don't capture that on the image, you may miss the opportunity to make a definitive diagnosis. And again, I think that should be the goal. If we give an equivocal report for our surgeons, we haven't helped them. All right, don't quit too soon. And what I mean by that is you need to have multiple views of the anastomoses. One view is no view, but also you need to make sure that the anastomoses are bathed in contrast and that at some point during the exam they are in the contrast pool. And you can't do this if the patient remains standing for the entire study or if they remain in a supine position. And of course, as with all imaging, you need to beware of satisfaction of search. If you see one abnormality, push yourself to find additional abnormalities. So we're going to start with a total laryngectomy. Now in this case, this is a total laryngectomy with reconstruction via a radial forearm free flap. The surgeon takes a flap of skin from the forearm with the radial artery and draining vein and makes a neopharynx that's anastomosed near the base of the tongue and up in the cervical esophagus. So these are the areas where it will leak. It can also leak anywhere along the anterior portion because this is where the sutures are to make the neotube. Now, why is it important to get a scout image? Well, as you can see, these patients are complicated. They have surgical drains, they have vascular clips, they have skin staples. And in this case, it's probably not a big of an issue because in this view, you don't have a lot of overlap. But this is another patient, same surgery, total laryngectomy with a forearm free flap, and you can see vascular clips in the area that you're going to be looking for a leak. And it becomes problematic when sometimes you'll have a little bit of motion on an image and you may see a clip that's blurred a little bit, and then you're going to begin to equivocate. Could that be a leak? Is that a leak? So that's why it's helpful to have a scout image to go back and compare the clips that existed before you gave contrast. Don't quit too soon. We tend to want to get these patients in and out of our fluoro suite. They're sick, they hurt, they make us nervous. Tendency is to do the study as quickly as possible and get them out. You don't want to do that. Here's an example of you need to really focus on the history. This was actually a recent case of ours, not a postoperative, but a post-endoscopic. Was having dilatation of a distal esophageal stricture, post-procedure chest pain. Chest CT revealed pneumomediastinum. So this swallow was performed, and you can see contrast here that was thought to be pooling in the pharynx. And on the oblique view, and notice the oblique view where it's centered really on the upper thoracic and cervical esophagus. But we need to remember in these patients, endoscopic perforations typically happen higher in the pharynx, at the piriform sinus, or perhaps in the posterior hypopharynx in a patient that has a cricopharyngeal bar or an osteophyte. So we just aren't centered high enough here. And this was reported out as pooled contrast in the pharynx and possible leak here. Well, in retrospect, what we're actually seeing, only this thin string of contrast is intraluminal. All of this is extraluminal, but we're missing the point of perforation because it's above the edge of the film. Now, this patient went to the OR, had debridement, was brought back the next day for a follow-up study, and these are select images from the digitally recorded study. You can see the initial swallow, and as contrast goes down into hypopharynx, we can see this large posterior leak that still exists. So again, you need to be sure to center on the areas of concern, so you have to be familiar with that anatomy. Another example of not quitting too soon, this is a similar patient, total laryngectomy. Initial images were only obtained in the upright position, and it looked pretty good, didn't see a leak. However, brought the patient back, laid him down in a supine oblique, and there's a huge leak here. So you've got to be really careful. You can't study these patients standing only. You need to, at some point, make sure they're lying on the fluoro table. This is a great example of satisfaction of search. This patient had no less than 7 swallowing studies over the course of the year. They had a total laryngectomy, and unfortunately a stricture developed at the upper anastomosis. This patient came in 7 times to have the stricture dilated endoscopically, and each time had a follow-up study to evaluate the stricture. And in this case, we even gave a tablet to prove that yes, it's still strictured. What was missed on all 7 studies was the fact that there was a tiny leak, unfortunately extending to this patient's bone graft in their cervical spine fusion. So you've got to be careful about the satisfaction of search. So let's move downhill a little bit and talk about an esophagectomy with a gastric pull-up. Now, this can be done in several different ways. These are probably the 2 most common, the Ivor-Lewis, which is a right thoracotomy. Now this is often done with robotic surgery. Laparotomy is also performed so the stomach can be mobilized and pulled into the chest. Another approach is through the neck with a transhiatal esophagectomy and also a laparotomy. And there are pros and cons to both of these, but it's typically the surgeon's preference. And they typically postoperatively look about the same, except the transhiatals tend to have a little bit higher anastomosis. In general, you need to look at a few areas for leak. One is the oversewn edge of the gastric cardia. The most common site of a leak, though, is going to be at the esophagogastrostomy right here, and that's where nearly all of the leaks occur. You also need to interrogate the pylorus. Surgeons typically do a pyloromyotomy or a pyloroplasty, so we need to make sure that the stomach is emptying and there's no leak here. Our surgeons actually now inject Botox in the pylorus. So this is what a normal gastric pull-up looks like. Patent anastomosis, no leak. Gastric body is pulled into the chest, and remember, because they've been mobilized, they've been denervated, and they typically don't empty well. So this is a patient population that it's particularly important to make sure that you drain out the contrast before you send them back to the room if they're obtunded or if they came on a stretcher. Another example of don't quit too soon. Here's a patient that had a gastric pull-up, was studied on postoperative day 2, and found to have no leak. Patient was brought back 2 days later because the surgeon noticed increased drainage. And sure enough, we identified a leak here. In retrospect, you can see a peaked area here. It's hard to know if that would have leaked or not. Is it because they weren't rolled in enough positions? It's hard to know. But you need to make sure that at all points that all components of the anastomosis are bathed in contrast. Here's another example of a patient that looked normal, but only supine frontal views were obtained, and you can see the patent anastomosis here. Only when you rolled them into a fairly steep oblique could you see this anterior leak here. This is a different complication in a patient with gastric pull-up. This is a stricture at the anastomosis, and you can see the jet effect here as the contrast courses through the stricture, the proximal ballooning with the retained contrast. And finally, some of these patients, when they leak, as here at the anastomosis, it communicates with the airway, in this case the left mainstem bronchus, and you can see the contrast entering into the peripheral airways. This raises a concern. We have transitioned all of our upper GI studies to low osmolar contrast agents. We don't use gastrographin or gastroview because of the risk profile. In this case, if that would have been used, that would have been a high risk of acute pneumonitis. So for any of our studies, typically proximal to the ligament of Treitz, we use low osmolar agents. These leaks that communicate with the airway are typically treated with a covered stent placed by the endoscopist. We're often asked to evaluate these and make sure that the leak has sealed off. In this case, it did. We saw no more communication with the airway. But these stents are a little bit problematic because the distal end is not well seated in that gastric body, so it tends to move around. They often pass spontaneously into the stomach, and that's fine. They're retrieved. As in this case, here's another case which was, this was a different patient with a leak at the anastomosis, communicated with a bronchus on the right, you can see here. So a stent was placed. We saw no more communication with the airway. However, the patient was brought back because the stent had passed distally. The endoscopist removed it, and we brought them back to see if they had a leak. We saw this large ulcer in the stomach that was created by the stent eroding through that gastric wall. And unfortunately, they also still had a communication with the airway. So the endoscopist placed a second, slightly more proximal stent, and this patient did fine, but you can still see that large ulcer crater from the stent. So let's talk a little bit about reflux procedures, as they are incredibly common. This is a normal Nissen fundoplication, which is a complete 360-degree wrap. It should extend for about 3 to 4 centimeters around the gastroesophageal junction and be seated below the hemidiaphragm. Here's a normal Nissen as well, and you can see the fundoplication filling defect here in the fundus of the stomach. And again, it should extend for about 3 to 4 centimeters and be positioned below the diaphragm. This is also a normal toupee fundoplication, and what you notice here is contrast is actually extending into the wrap itself. That does not necessarily mean that the wrap has dehisced. It may simply reflect that the patient had been rolled into multiple obliquities, so don't be disturbed if you see wrap filling with contrast. Here's a patient with too tight of a wrap. You can see this narrow shoestring of contrast and the proximal pooling of contrast, and actually probably food from a few days gone by. This is the most common complication we see after fundoplication. Some people refer to this as a slipped wrap, where you see the wrap extending around the proximal stomach. It's too low because we see gastric folds extend well up into the chest. The gastroesophageal junction is here in the chest, and this patient has a short esophagus. In actuality, this is probably not a slipped wrap. It was probably an inappropriately placed wrap initially because of failure to diagnose the short esophagus. Another patient here, the wrap has mostly dehisced, but you can see it's clearly too low, extending around gastric folds. The GE junction is here as well into the chest, and this patient with a short esophagus. This patient has an intact wrap here, unfortunately is moved into the chest, and you can see the hiatus here as the pinch where the gastric folds cross the diaphragmatic crus. And finally, another example of satisfaction of search. This was a patient that had fundoplication surgery, was having recurrent chest fullness. The surgeon suspected that there was failure of the wrap, and sure enough, although the wrap was intact, and you can't really tell that here on this image, there was a recurrent hernia. But what was initially missed was this large gastric ulcer, probably the cause of the patient's symptoms, not the recurrent hernia. So let's move on to a little bit of bariatric surgery, and we'll start with the Roux-en-Y gastric bypass. These patients have a roughly 1 to 2 ounce pouch that is created from the stomach, the gastric cardia specifically. They have a blind roux limb here, and then the roux limb extends into the abdomen. Now, the places that we need to look for leak are here. The majority of the leaks do occur here, at least 75%. A small number occur here at the blind limb. And fortunately, very few leaks occur distally because this can be a difficult area to interrogate because of the overlapping bowel loops. This is a normal gastric bypass pouch, about 1 ounce. Here's the gastrojejunostomy. Again, this is the most important place to look for leak. Sometimes in the immediate postoperative period, you have edema, typically for 24, maybe 72 hours, and this resolves. This was a patient that had a little more edema than we typically see at the gastrojejunostomy, but this patient did fine. And then remember to look distally at the jejunojejunostomy. Now, in this case, it's easy to see because the patient actually had too short of a roux limb, but sometimes it is very difficult to identify this distal portion. But you don't want to quit too soon. You want to make sure that you feel the contrast has passed beyond this distal anastomosis. Here's another example of quitting too soon. Initially, this was thought to be the roux limb, and this was an underfilled blind portion of the roux limb. With additional contrast and additional repositioning, we actually realized this is the roux limb, this is the blind limb, and this is actually extraluminal leak. Now, what's important for us to determine is that leak into the residual gastric body, also referred by our surgeons as a gastrogastric fistula, or is it a free leak into the peritoneal cavity? This is key. If it's a free leak, they require immediate surgical intervention. If it's a gastrogastric fistula, the surgeons often sit on this and won't operate unless the patient has inadequate weight loss, and then they'll intervene. When we continued to reposition this patient, it was clear that this was spreading out under the hemidiaphragm and a free intraperitoneal leak. Now, here's an example of the gastrogastric fistula. You can see the pouch here, but you also see contrast filling another structure with gastric folds, and this is confirmed with emptying into the duodenum. So this is a gastrogastric fistula. And this is another patient, gastric pouch here. Here's the roux limb. Here's the blind roux limb. Extraluminal contrast was thought to be communicating into the gastric body, again a gastrogastric fistula. However, with repositioning and specifically placing the patient into an LPO position, you can see it freely spilling into the peritoneal cavity. So that's an important differentiator for us to make, and it's really not one that we can hedge on. Marginal ulcers are fairly common, and they're more often seen in patients who have too large of a pouch. They typically occur, as in this one, at the gastrojejunostomy. Another marginal ulcer here actually had an edema and a ball valve effect that was obstructing emptying of the blind limb of the pouch here. And here's another patient demonstrating a leak from the gastrojejunostomy, and again, the unexpected communication with the airway, emphasizing the importance of using low osmolar contrast agents in these patients. So let's close with a quick discussion on gastric band and then also on the gastric sleeve. So when we evaluate gastric bands, we look for the angle, the phi angle, as we see here. We draw a line through the spinous processes, a line through the thick portion of the band, and this angle should be roughly 4 to 58 degrees. And this is a normal appearance of the band. If the angle is different from that, it suggests a slipped band. Now, I can't remember those angles, so I do things simple. I look for the placement roughly at the 2 to 8 o'clock position on a clock, as in this one. This is a normal appearance. Another normal angle here, slightly flatter, but still within the range of normal. And the contrast as it courses through the band should be about 3 to 4 millimeters in caliber, as we see here. This is a normal appearance. Now, this person has a lap band, but you don't know it because, unfortunately, a protocol upper GI study was performed, which is not helpful in this case. You don't need to perform a double contrast study because it precludes you from adequately evaluating emptying across the band. That's why it's important we obtain good history to start so we can do the appropriate exam. This is a patient that demonstrates a band, the O sign, which is another finding of a slipped band. Instead of appearing as a bar, it looks more like an O. This is another patient that also has a partial O sign, but note the band is more than 2.4 centimeters below the hemidiaphragm, or twice the width of the band. That's another finding, and actually a more sensitive finding for slip band, and also an air fluid level in the proximal pouch. And that was confirmed with fluoroscopy and contrast, and you can see here the band has slipped distally, and you have proximal retention. This is another patient with the O sign of a slipped band that's completely obstructing the proximal dilated pouch. And another patient here, too tight. You can see this string-like contrast. In additional contrast, you can see a large pooling of contrast proximal to the band. And finally, this is a patient with a chronic, nearly obstructed band that's created a massively dilated pouch and actually pseudoachalasia that you can see here on this CT scan because of the long-standing too tight of a band. And finally, this band was completely obstructed, as we see here. And we'll end with gastric sleeve. A gastric sleeve is tubularization of the stomach to decrease its capacity with resection of the greater curve. And these are the areas that we need to look here for leak. Again, we also need to confirm there's emptying across the duodenum. Now, the residual gastric sleeve may have some bizarre appearances, but the most important thing for us to tell the surgeon is, 1, there is no leak, and 2, that there is emptying into the duodenum. Now, leaks in gastric sleeves tend to be massive, And in this case, you can see this huge leak, this extraluminal contrast on the CT scan. So with that, hopefully we've visited some of the surgeries that you will see in the upper GI tract. You have a better understanding of how to safely prescribe the contrast agents for these patients and diagnose their complications. With that, I'm going to hand it over to my friend, Dr. Eric Paulson, who's going to talk about the postoperative pancreas.
Thank you very much, Dr. Sherry Cannon, and it's a delight and a true pleasure to have an opportunity to present to the RSNA, and I'm appreciative of the RSNA for inviting me to give or to participate in this session. So I'm going to talk about imaging the postoperative pancreas. And let me tell you that this talk is based on material at my institution, which is Duke University, also based on knowledge and images borrowed from a review article written by Kumar Chandrasekaran from the University of Indiana, as well as from Dr. Morgan at the University of Alabama. As you know, pancreatic diseases are complicated and difficult, and the pancreatic surgeries are complicated and difficult. Pancreatic resection is really the only way to impart a significant survival benefit or possible cure in patients with adenocarcinoma, and is occasionally used in the management of patients with chronic pancreatitis. In patients with pancreatic duct obstruction and chronic pancreatitis and chronic pain, pancreatic duct drain procedures are sometimes used. I'm going to talk about the postoperative appearance of both of those. I'm not going to talk about either autologous or whole organ pancreatic transplantation. In the early postoperative setting, we use CT to detect complications, and frankly, in the more remote postoperative setting, when looking for recurrent disease or restaging, we use CT as well. We use MR when the question has to do with the integrity of the biliary anastomosis, and sometimes use an hepatobiliary agent. Hardly ever use fluoroscopy in the setting of these, in the setting of the postoperative pancreas, at least in our practice. Let me make a shout out to Dr. Alan Oldfather Whipple, who in the 1930s modernized pancreatic surgery, developed a two-stage approach to pancreatic head resection. That's been modified since then, but that procedure, which is the most commonly performed pancreatic head procedure, carries his name. This is what the post-op Whipple anatomy looks like. And it's usually done for patients with tumors in the head of the pancreas, as in this case of an adenocarcinoma causing biliary and pancreatic duct dilatation. With this procedure, the pancreatic head and the tumor in its entirety, hopefully, is resected, but also resected is the duodenum, the gastric antrum, the pylorus, the proximal jejunum, the distal common bile duct, sometimes almost the entirety of the common bile duct. Gallbladder is resected, and lymph nodes will be sampled. A place where complications and recurrence occurs is the pancreatico-jejunal anastomosis. Sometimes we call that the Whipple anastomosis in our practice. And frankly, I think they're difficult to find. These are three different patients, 2 CTs, 1 MRs. You kind of find the residual pancreas, follow it up to something that looks like a loop of bowel, and that's where the anastomosis is going to be. Sometimes you get lucky and there's a pancreatic stent, which is often left, by the surgeon to decrease the possibility of an early postoperative leak. And here is what that pancreatico-jejunal anastomosis might look like on an MR scan. On a coronal view, pancreatic parenchyma up to the pancreatico-jejunal anastomosis. This patient happened to have a postoperative portal vein thrombosis as well. The hepatico-jejunal anastomosis is also tricky to find. One of the reasons it's tricky to find is sometimes almost the entirety of the common bile duct is taken with this procedure. So what I do is I follow the residual common bile duct down to the jejunal loop, and at that junction, of course, is going to be the hepatico-jejunal, or sometimes called choledocho-jejunal anastomosis. MR lends itself to looking at those really nicely. Here's an MR, and you can see the pulled up loop of jejunum, the pancreatico-jejunostomy, and the hepatico-jejunostomy right there. These patients also undergo a gastrojejunostomy, and typically for the classic Whipple, the one that's done most commonly at our institution, this gastrojejunostomy lives in the left upper quadrant, near where you'd expect the gastric body to be, and this one happened to be filled with gas at that particular point in time. Another variant of the Whipple procedure, or a variant of the Whipple procedure, is called the pylorus sparing pancreatico-duodenectomy. That's also called the Longmire procedure by many pancreatic surgeons. This is a lot like the Whipple, except that the pylorus, the proximal duodenum, and gastric antrum are left intact. Pancreatic head is resected, duodenum is resected, proximal jejunum is resected, distal common bile duct is resected. Why might you leave the entire stomach in? Well, the theory here is that these patients have better GI function and therefore better nutrition and weight gain postoperatively. I don't know that that actually is true in practice, but that's the reason the Longmire variation was popularized. The difference between the post-op pylorus sparing surgery and the traditional classic Whipple is that the gastrojejunostomy, imaging-wise, tends to be on the right of midline because the entirety of the stomach is left intact. Whereas in the classic Whipple, the gastrojej is usually in the left side of the abdomen. Now, as these patients tend to be resected for ductal adenocarcinoma, and as ductal adenocarcinoma has a proclivity to encase arteries and veins, at some sites these procedures are performed with a vascular resection. That vascular resection is not done at all places. It's somewhat controversial, but some studies have shown that it imparts a survival benefit compared to a standard Whipple. So if there's a patient that's otherwise resectable but who might have some encasement of the portal vein, as in that particular case, there are some choices that a vascular surgeon can employ to make these patients completely resectable for cure. In general, the criteria for when this might apply has to do with 2 centimeters or less of contact with the superior mesenteric vein or the portal vein. Sometimes the surgeons will anticipate a Whipple based on preoperative imaging for cure, and will find peritoneal-based disease, microscopic disease, maybe find some positive lymph nodes that weren't anticipated preoperatively. And in that scenario, it doesn't make sense to do a full Whipple. That would be too morbid for a patient with that sort of prognosis, but particularly in patients who might have had preoperative clinical features to suggest gastric outlet obstruction, we'll go ahead and do a palliative gastrojejunostomy, which you see right here. Another pancreatic procedure, which is done less frequently in our institution, is a central pancreatectomy. Here, the central aspect of the gland is resected. It's generally reserved for tumors that are a little more indolent than ductal adenocarcinomas, such as neuroendocrine tumors or cystic neoplasms of the pancreas. A predicate of this procedure is to have enough pancreatic tail left behind to justify leaving it behind. And here's an example of a mucinous cystic neoplasm that underwent a central pancreatectomy. These patients, of course, have the central pancreatic gland resected with the tumor, and have an anastomosis at the pancreatico-jejunal anastomosis and a jejunal anastomosis as well. They tend to have leaks. Sometimes you'll get leaks at this pancreatic duct anastomosis or transection site right there. Here's a postoperative example of a central pancreatectomy. Note the pancreatic tail, note the pancreatic head, but the central part of the gland is occupied by this pancreatico-jejunostomy, and the surgeons will often leave a little tag, a little windsock, a little bit of extra jejunum, and you can figure that out by the little surgical anastomosis right here left behind, and sometimes that can be a source of confusion, and sometimes that can mimic recurrent tumor. As I said, these patients are prone to leak, and here is a leak right here in a patient after a central pancreatectomy. One of the more straightforward, if any of these are straightforward, one of the more straightforward pancreatic surgeries is the distal pancreatectomy. Here, the ampulla doesn't need to be messed with, and that's where many of the problems from the Whipple, classic Whipple procedure occur. This is for lesions in the pancreatic tail, like this islet cell tumor right here. Pancreatic tail resections can be performed laparoscopically, and when the pancreatic tail lesion is larger, the spleen usually comes out. Sometimes it's possible to save the spleen in the splenic vein, and that's important for fighting infection in the future. And here's an example of the transection margin. Pancreatic tail is completely missing. This person also had their spleen resected when their pancreatic tail lesion was resected. What on first glance looks a little bit like the postoperative Whipple is actually the appearance after a total pancreatectomy. Here the entire gland is resected, and there is also resection of the antrum, duodenum, proximal jejunum, spleen, gallbladder, most of the common bile duct, and lymph nodes will be sampled as well. Why in the world would you do such a big procedure? In a subset of patients with chronic pancreatitis in whom it's not clear if the pain is from the head of the pancreas or the tail of the pancreas, sometimes those patients will undergo, for palliation, an entire complete pancreatectomy, total pancreatectomy. There are some patients who have multicentric neuroendocrine tumors where the whole gland needs to be resected. There are some patients with an extremely high risk for pancreatic adenocarcinoma, and preemptively those patients may undergo a total pancreatectomy. Haven't seen very many of these in our practice. Here's what one might look like. Pancreas is completely missing. Here is the hepatico-jejunostomy, or here is the jejunal loop right here, and here is the hepatico-jejunostomy right here. Note the gas in the biliary tree. First of all, it helps you identify where the anastomosis is, but also if there's gas in the biliary tree that's refluxed up through the loop of jejunum, that suggests the anastomosis is patent. Pretty good evidence for patency there. Another surgery that's increasingly performed is simple enucleation of the pancreas. This is an islet cell tumor right here. And in the kidneys, it's pretty, easy, relatively straightforward for a surgeon to wedge out and pop out a peripheral renal lesion. Same thing in the liver, not so in the pancreas. The pancreas doesn't like to be messed with. It's got a bunch of little side branches in it that can leak pancreatic juice, that can wreak all kinds of havoc. And after the enucleation of this particular lesion, which looks straightforward, this person wound up with a pancreatic side branch leak and needed a percutaneous drain of that procedure. By the way, surgeons are loath to go back in on these patients in the early preoperative setting and will do almost anything to manage them endoscopically or with time and antibiotics or with percutaneous drain. This now brings me to the pancreas drainage procedures. The classic one is the so-called Postoperative procedure, or the lateral pancreatico-jejunostomy. Here, the patient has a chronically dilated pancreatic duct, usually with multiple strictures, a so-called chain of lakes appearance, may have stones in the pancreatic duct, and a loop of jejunum is excised, or a loop of jejunum has a longitudinal transection within it that is laid over the pancreatic duct in a fashion such as this. So these patients tend to have a pancreatic duct that's dilated up to about 7 millimeters, and the loop of jejunum will drain this dilated pancreatic duct. The idea is that that will cure their pain. Doesn't always work. They'll ask postoperatively, is that pusto anastomosis intact? Is that pancreatico-jejunal anastomosis intact? And all you can do is infer that it's intact and working if the pancreatic duct is not dilated. Here are a bunch of little stones, but the pancreatic duct is now being drained nicely into that pulled up loop of jejunum. A sort of cousin operation to the pusto that is reserved for patients with chronic pancreatitis in the head and unrelenting pain is the Becker procedure, similar to a Whipple, but the head is taken and drained, the remainder of the pancreas is drained into a pancreatico-jejunostomy. The idea here is for pain relief. So these are done in patients who have head-dominant chronic pancreatitis without a dilated duct. The dilated duct patients tend to undergo a Whipple procedure, and I'm sure that the approaches vary from institution to institution and country to country. A few words about complications, because these patients are prone to complications in the early postoperative setting and are prone to recurrent disease in the more remote postoperative setting. So let me talk about some of the complications. First of all, in the early postoperative period, there's lots of things left over by the surgeon. You may see pancreatic stents like this one. Those are designed to keep those anastomoses intact and decrease the likelihood of a leak, and they often fall out, and it's not that big of a deal if they fall out. And you'll see surgically placed drains, and you'll see clips in the porta hepatis and GI anastomosis staples in these patients as well. The pancreatico-jejunal limb or the Whipple limb or the pulled up loop of jejunum, whatever language you like, can be quite variable. This is the same patient, two different series in the same CT scan. Here the loop had collapsed. Here it had filled up with gas and fluid. It can mimic an abscess. It can mimic recurrent tumor. It can be confusing to figure out. It's particularly confusing if you have learners in your practice. Postoperative fluid is the norm after pancreatic surgery. I think a lot of patients after pancreatic surgery also have evidence of a little bit of leak in this postoperative fluid from one of the anastomoses. So you'll see fluid around the surgical site, in the free intraperitoneal space, and in the fascial planes. In fact, 30 to 50% of patients early on after a Whipple, like in the first week or 10 days, are going to have a significant amount of postoperative fluid. It's really a normal finding. What you worry about in the Whipple and what's a contributor to the significant morbidity of a Whipple procedure is a pancreatic duct leak, which is shown right here. In fact, pancreatic duct leaks in various series occur in 15 to 20% of these patients. And it has to do with the fact that the pancreas is hard to sew, doesn't take stitches well. It's tougher to sew than like a loop of GI tract is. It's particularly if it's a normal gland. If it's a chronically inflamed gland and is more like a piece of leather, the surgeons can sew into it just fine. But if it's a normal pancreas with a tumor adjacent to it, that normal pancreas is difficult to put a stitch in, apparently. One of the things that'll be the clue to a leak is a surgeon will send the fluid coming out of their drains for amylase, and if it's amylase rich, that implies that the Whipple anastomosis is leaking. And generally, those patients will not go back to surgery because the surgeon can't do much. They will simply manage those patients in some other fashion. Here's one where a pancreatic duct leak turned into a fluid collection that was approached in this case endoscopically, and there you can see the guide wire and a nice post-procedure result right there in a patient who had a pancreatic tail resection. Here is a patient with a dual energy CT acquisition from our practice. This is the iodine, so-called iodine-only image, which shows very nicely this vividly enhancing mass in the pancreatic head, which of course is going to be an islet cell tumor of the pancreas. Looks like a straightforward resection, but post-operatively this person looked like this. Lots of loculated fluid collections. These collections had not only pancreatic fluid, but bile as well. And in our institution, we approach those percutaneously all the time. In fact, one of our fellows a few years ago looked at our experience at Duke University. About 1 in 5 patients required some kind of percutaneous intervention, sometimes just an aspiration, in the patient after a Whipple procedure. Hemorrhage doesn't occur very often, does not occur very often, but it can occur. I think hemorrhage is more likely to occur in the patient who's had pre-existing chronic pancreatitis because their blood vessels are more fragile than patients who haven't had that. And here's a hemorrhage with some active extravasation within it. And here's a post-op fluid collection with some gas bubbles, obviously suggesting the presence of an abscess. In our practice, those patients would come right on down for a percutaneous drainage procedure. Some sites will approach these patients surgically. Here's a surgically placed cyst gastrostomy, and I show this just to point out that the peripancreatic cyst after a cyst gastrostomy fills up with gas and debris from the stomach, and they always look nasty, they look bizarre, they look like they ought to be infected, but if the cyst gastrostomy is patent, they're not. That's simply just expected postoperative appearance, and they will heal in like this one did over time. They don't heal into complete normal, but they heal in pretty nicely like this one did over time. Here's a patient who had a cystic tumor, sort of a unilocular, not otherwise specified cyst in the uncinate process of the pancreas. Looks like it ought to be a straightforward procedure and what's probably a fairly benign tumor, but postoperatively there was a disaster with GI leak and massive free intraperitoneal air, bowel ischemia, pneumatosis, and all sorts of complications. Doesn't happen very often, but it can occur. Here is one borrowed from the literature of a person who had a lateral segment liver infarction after pancreatic surgery. Again, doesn't happen very often, but did in this particular case. Post-operatively and remotely, these patients struggle with nutrition. They often wind up with chronic fatty infiltration of their liver. As you see in this particular case, they're also prone to other complications. Here's a pseudocyst which was picking off the pancreatic duct, causing obstruction of the pancreatic duct, and could be drained either percutaneously or endoscopically, depending upon your preference. These patients are at risk for recurrent tumor. One of the places to look is in the region of the Whipple anastomosis at the resection margin. Look for early metastatic disease in the liver in these patients. Look for vascular encasement. Look for evidence of peritoneal carcinomatosis, here characterized by the peritoneal thickening and infiltration of the gastrocolic ligament. Here's a patient with advanced metastatic disease following pancreatic surgery, huge tumor growing into the porta hepatis, a stent within a stent, biliary dilatation, probably a portal vein thrombus in there somewhere, end-stage metastatic disease after a Whipple. So, in summary, the post-operative anatomy in these patients is a little confusing, a little difficult to remember, and there are variations in approach from institution to institution and country to country, I suspect. The roux limbs or the hepaticojejunostomy loops or the pancreaticojejunostomy loops often fail to fill with oral contrast, so if you try to use oral contrast to identify those, that doesn't help very often. They may mimic an abscess or recurrent tumor as a result. I find it critical, as Dr. Cannon pointed out, critical to review operative notes and the medical record to try to figure out what a surgeon has done. Even if you do that, it can be difficult to figure out what a surgeon has done. And in the more remote setting, look very carefully for subtle recurrence. Thank you very much for your attention. Our next speaker is Dr. Philippe Soyer from Paris, France, and he's going to talk about the postoperative liver. Philippe.
Thank you, Eric. Thank you. So, good morning to everybody, and thank you for being here. During the next 20 minutes, I would like to become familiar with the expected appearances of the liver following surgery, and I would like to highlight the complementary role of the different imaging techniques in the diagnosis of postoperative complications. I would like you to become familiar with the imaging features of early and late complication, including recurrence of the initial disease. And I would like you to understand how the different imaging techniques are complementary for the diagnosis of complications and how they can help for management decision. Though this is organization of the presentation, we will start with a brief overview of the liver segmentation. After that, we will get through the different types of surgical resection. I will get through into the normal postoperative findings, and then I will show you some early postoperative complication. I will finish with the late postoperative complications. So the liver segmentation, as you know, is a three-dimensional concept, and this anatomy is based on the intrahepatic distribution of the portal branches and the hepatic veins. And as a landmark, you have the middle hepatic vein that divides the liver into right and left hemiliver, which were previously called American lobes. You know, some of you are familiar with the terminology, the American lobes, and I think it's more correct to use right and left liver or right and left hemilivers. And if each of these hemiliver is further divided by the right and the left hepatic vein into medial and lateral sections, and these sections were previously called segments when using the terminology of Goldsmith and Woodburn, which is probably more familiar to you. But again, it's more correct to use now sections instead of segments. And there are four sections: the right lateral, the right medial, the left medial, and the left lateral section. And each of these sections is divided into superior and inferior segments by an imaginary transverse plane, which is called the transverse caesura. Let's get through the different surgical types, resection, different types of surgical resections. Liver resections consist of anatomical resections and atypical resections. Anatomical resections are right or left hepatectomy, the sectionectomies, and the segmentectomies. And atypical resection are often complex resection, combination of different resection or wedge resection. This is a nomenclature that has been developed by the America's Hepato-Pancreato-Biliary Association, and I think it's very important to know this nomenclature and this description, because I think that the radiologist and the surgeon have to speak the same language. So when you talk about right hepatectomy, you perform a resection of the right hemiliver, that is a segment 5, 6, 7, and 8. And when you do a left hepatectomy, you remove the segment 2, 3, and 4. And the segment 4 can be further divided into a superior segment and inferior segment. This is an old description by Bismuth. And there is a superior segment, which is the 4A, and inferior segment, which is the 4B. Sectionectomies consist in resection of segments, and there are 4 sections that each of these contain 2 or 1 segment. And you have the right anterior section, the right posterior section, the left medial section, and the left lateral section. Segmentectomies can be done to remove a single segment, and sometimes you can combine 2 segmentectomies. That's called a bisegmentectomy. Atypical resection, this is an example of a wedge resection. This is done to remove a superficial tumor of the liver. So now let's get through the normal postoperative findings. They can be categorized into 3 groups. One can be considered as a surgeon trace. One consists of morphological changes, and one consists of fluid collection. One of the most evident, the most easily to identify postoperative findings is the presence of surgical metallic clips, and they are usually located at the resection margins. They are very easily identified on CT. Another postoperative finding in the presence of an epiploplasty. Epiploplasty is often performed after a right hepatectomy to fill the operative cavity. And in general, epiploplasty is located adjacent to the resection margins. It has a fat density attenuation and contains some internal vessels. Sometimes epiploplasty can be misleading, and it may mimic infected fluid collection, as in that case, the patient has a central hepatectomy, but you can differentiate between epiploplasty and a more critical complication, which is an abscess or a fluid collection. In that case, epiploplasty has no peripheral rim, no capsule, and the margins are pretty ill-defined. Vascular ligation, when the surgeon has used a metallic clip, can be visible on CT. And MDCT is also a nice tool to check for the correct placement of the surgical drains. They can be placed after a major resection usually, and they are left in place for 4 days. Sometimes they can be located in unexpected locations, so you have to check all the examination to check for the correct placement of the drains. The other group of postoperative findings consist of organ displacement. This is a result of the basic concept of oral vacui, and when you remove portion of the liver, other organs want to fill the empty cavity, and can be the colon, can be the stomach, can be the pylorus, as in that case. The kidney can move upstairs to be a little bit higher than usual, and sometimes the colon, after a major resection, can be located between the liver and the abdominal wall. Sometimes organ displacement can be confusing. This is a case of a patient who had a left hepatectomy, and the stomach came close to the liver, and if you are not very confident with the diagnosis of organ displacement, you can repeat the examination and make a repeat examination after oral administration of contrast or water, just to make sure that it actually the stomach and not an abscess. Another group of normal postoperative findings is the hypertrophy of the remaining liver. You know that after resection, there is a considerable increase in liver volume, and this has this can be visible on CT scan. Usually the patient with the greatest enlargement of the remaining liver had patients who had a combination of preoperative portal vein embolization and extended or right hepatectomy or extended right hepatectomy. And this is the case of a patient who had a major increase in the remaining liver volume after right hepatectomy. And also this is an accompanying enlarged left hepatic artery. This is a typical feature of the remaining liver after extended right hepatectomy. The remaining liver, this is a left lateral section, has a round shape, and this is clearly visible on this coronal view. Sometimes the remaining liver has not a rounded shape, it can be elongated, but it's just a variation, it has no impact of the outcome. Finally, a normal postoperative finding, which is very frequent and almost constant, is the presence of fluid collection at the resection margins. Usually fluid collection disappear within 4 or 10 days, and usually there is a progression in volume reduction. And in that case, the patient had a remaining fluid collection with bubble inside. So in such cases, you have to change the drains. And this was because the drain did not work properly, because there was a kinking of the drain. So if you have a persisting fluid collection, I advise you to change the drain. Fluid collection can be limited. In that case, this is a patient who had a wedge resection and there is a small fluid collection at the operative site. Fluid collection sometimes can be misleading. This is a recent case we had, and we were very concerned about this fluid collection with gas bubble inside, and unfortunately the patient had fever too, so we did a direct puncture of the fluid collection. There was no pus, no germs, nothing, and we went through the operative report and we observed that the surgeon used an hemostatic agent. It was Surgisol in that case, and it is very important to know the type of resection and look through the operative data to make sure that the patient had actually a simple procedure, and it's very important to make the interpretation of the examination with knowledge of what has been done during surgery to avoid unnecessary procedures. This is a case that shows the natural history of fluid collection. You see that it disappears with time, and usually there is a fibrous retraction at the resection margins. Now we will get through the early postoperative complications. Postoperative complication consists of fluid collection, thrombosis, and biliary injury. Arterial injury after liver resection is less frequent. It's more often observed after orthotopic liver transplantation. Fluid collection are predominantly located adjacent to resection margins. Most of them are seromas and hematomas, and less frequently biliomas and infected collection, but sometimes you have to look at the diaphragm and check for subphrenic collection, which are not rare. For the diagnosis of fluid collection, we suggest that MDCT should be preferred because it has higher degrees of specificity for fluid characterization compared to sonography. And this is a case of postoperative hematoma. The blood is hyperattenuating, and MDCT is a useful examination to check for the decrease in the volume of the hematoma, and this is an indicator of favorable outcome. Sometimes fluid collection can be worrisome. This is a patient who had radiofrequency ablation and wedge resection for hepatic metastasis, and the patient had an infected hematoma. Infection was suggested by the presence of gas bubbles. MDCT helped perform fluid sampling, and then because there was pus and germs, the patient had a percutaneous drainage. He felt much better after that. MDCT should be preferred also because it can depict active bleeding, and this is a case of a patient who had surgery and there was a substantial drop in hemoglobin level, and the patient had an active bleeding and he was treated by percutaneous embolization. MDCT should be preferred also for the analysis of fluid collection. Pleural effusion are common findings after liver surgery, but it should regress and decrease with time. And in this patient, there was no decrease, there was rather an increase in the volume on the pleural effusion. So MDCT was performed and showed this communication, this fistula that was due to an intraoperative diaphragmatic injury. Thrombosis can be observed after liver resection. They are relatively rare after liver resection compared to orthotopic liver transplantation. And most frequently, thrombosis involves segmental portal branches or the remaining portal stump after liver resection. Hepatic vein thrombosis are usually observed adjacent to resection margins that can be considered as an acute Buerkeri syndrome, and sometimes it's a different type of hepatic vein occlusion. It's not a thrombosis, it's due to a kinking or a torsion of the hepatic vein after right hepatectomy. This is a very rare complication, but you have to think about and be aware of this potential complication because it's potentially life-threatening and the surgeon has to reoperate the patient very quickly. This is a case of a portal thrombosis of the right portal branch stump after a right hepatectomy. There is no specific treatment. It is an incidental finding, but you have to look at the portal vein, whatever. And this is another potential complication, which is a segmental portal vein thrombosis, which can be observed after a right hepatectomy. This patient had HCC and had a right hepatectomy, and he had segmental thrombosis visible on the postoperative CT scan. Portal thrombosis in some occasions can be complete. For sure, Doppler sonography is excellent at showing portal thrombosis, but CT is also a very good examination because it can show the thrombus as a hyperattenuating clot inside the portal vein, which is enlarged, and after injection there is a lack of enhancement of the portal vein and some perfusion abnormalities of the hepatic parenchyma. Thrombosis of the hepatic vein can be incomplete or complete. This is a case of incomplete thrombosis after hepatic resection. Biliary injury is not often visible after liver resection. It is observed in 4 to 5% of cases after major resection. And CT and MR imaging can show a non-specific fluid collection at the resection margin. Some authors use gadocetic acid because it has a biliary extraction, so you can see on MR leak with enhanced leak due to the leak of gadocetic acid after injection. This is a very good examination to confirm the biliary leak, but in our experience, the definite diagnosis of biliary leak is obtained with a direct biliary opacification, and when you do that, you can do in the same time a percutaneous treatment of the biliary leak using a covered stent. Sometimes you can observe some traumatic injury of the diaphragm, which was performed during the operation, and this may cause a kind of herniation of the small bowel through the diaphragm that can be responsible for small bowel occlusion, and MDCT is very helpful in that case because clinically it's very difficult to differentiate the ileus due to the use of anesthetic drugs and actual occlusion. And sometimes you have to manage some unexpected complication. For sure, this is a patient from another institution, and he was referred to us for the follow-up of treatment by radiofrequency ablation of this metastasis. And when we did the MR imaging, the patient had radiofrequency ablation of a wrong target. So it's a difficult case to manage because you have to talk to the surgeon and talk to the patient that he has to do something, a repeated treatment. Now we will finish with the late postoperative complications. Postoperative complication consists of initial disease recurrence, and sometimes when the surgery has been difficult, when interior injury has occurred, the patient may have ischemic cholangitis. Disease recurrence is best observed with MR imaging. We advocate the use of MR imaging for HCC, and we combine the T2 weighted imaging, the gadolinium enhanced imaging, and diffusion MR imaging. If you face patient with hypovascular metastasis, if you do CT The best phase is the portal phase. You know, the portal phase is best as depicting hypovascular metastasis. And when you do MR imaging, we advocate the use of gadolinium enhanced phase and diffusion weighted imaging to best depict the metastasis. It's a specific case of hypervascular metastasis. This is a patient with a carcinoid tumor with intrahepatic metastasis of carcinoid tumors, and we believe that this metastasis, this specific type, is better depicted with diffusion weighted MR imaging. One thing to know, if you look at the liver for depicting recurrence, please don't look only at the liver, but look also to the entire abdomen. This is a patient who had resection for hilar carcinoma. He had the local recurrence at the anastomotic site. But if you look carefully at the examination, you see that the patient has also a nodule in the small bowel loop, and the patient ultimately had peritoneal carcinomatosis. Ischemic laryngitis can be seen on MDCT, but MRCP is usually much better for this diagnosis. This is a case of a patient who had the right hepatectomy, and follow-up MR imaging showed the association of bile duct dilatation and bile duct stenosis, which was consistent with ischemic laryngitis. So, as a conclusion, I'm a little bit late, I'm sorry about this, but it's a dense topic. It's very important to know the type of resection when you do your report, when you do your examination. It's very important to know what has actually been done, and it's important to know also if the surgeon has had some difficulties during surgery. Fluid collection usually in the majority of cases belong to normal findings, and early complications are predominantly abnormal fluid collections. Late complications are predominantly recurrence of the disease. And remember, look at the liver, but not only at the liver, and you must be careful and check for the vessel. Thank you very much for your attention.
Okay, for those of you who are staying with us, we are at the end of the GI tract now, and I'm going to review our imaging of the post-op colon. I'll start by reviewing a little bit of anatomy and what the surgery entails, and then from there we'll talk about how we image that. If any of you have been to colon cancer refresher courses during the week, you will have seen this slide. 50% of the Western population will develop a colorectal tumor by age 70. 10% of these will be a malignancy. In adult, colorectal cancer is the second leading cause of cancer death worldwide. So it's something that we look for and are involved with on a day-to-day basis. Just a little bit about colonic anatomy. Nice to remember that the colon slowly decreases in size as you go from ascending to rectum. The largest portion of the colon is going to be the cecum, and as you get towards rectum, it's going to decrease in caliber over the long course of the colon. It can be variable in length up to about 150 centimeters. There are 3 tinea coli, which are bands of longitudinal muscles, which will traverse the colon from the base of the appendix to the rectosigmoid junction. And this is a pictorial representation of the colon. Again, you can see that the cecum is the most capacious of all the areas or all the locations within the colon. A little bit about rectal anatomy, because this is going to become important as we talk about the rectal surgeries, and we go from there. As you remember, when the rectum transitioned to anus, we're at the dentate line. And this is an important area when we name a tumor, because if it's in the rectum, it's going to be of columnar epithelium, and it's going to be an adenocarcinoma, and in the anus, these are squamous carcinomas. You'll remember that the internal and external sphincter come in right just above the dentate liner, and these are important structures. The internal sphincter is going to be the smooth muscle of the rectum. The external sphincters are going to be the levator muscle complex involved in the external sphincter, and these make up sphincter tone. So when the surgeon is deciding what operation will best suit the patient's malignancy resection, it has everything to do with its relationship to the sphincter complex. The rectum is 12 to 15 centimeters in length, and it does not have tinea, epiploic appendices, or haustra. This area is unique in the way the peritoneum has reflections around the rectum. The upper third of the peritoneum is going to be covered anteriorly and laterally. The middle third is just anteriorly covered, and then the lower third is entirely extraperitoneal. And you can see that here, anterolateral, just anterior, and now the structure is retroperitoneal. And that too is important when we think about the surgeries that are performed. Colonic resection is based on the anatomic location of the tumor, and they're named for the location of the tumor. So if the surgeon is going to remove a cecal or right colonic mass, it'll be a right hemicolectomy. Left hemicolectomy is going to include the splenic flexure through the sigmoid colon. If it's just the sigmoid colon, it's going to be a sigmoidectomy. You guys are used to seeing this terminology. It gets a little bit more confusing when we're talking about rectal tumors, but again, if you just remember where the tumor is in relation to the sphincter complex, that's how the tumor, or that's how the surgery is named. A low anterior resection is going to be when the tumor is above the sphincter complex. The surgeons will remove the tumor above and the perirectal soft tissues above the sphincter complex with the tumor in place. These patients, if advanced in disease prior to resection, will get neoadjuvant chemotherapy prior to surgery to shrink the tumor. These are T2 and T3 lesions, and then they will get either a coloanal anastomosis then, or a pouch will be created. Ultimately, they are going to have an intact coloanastomosis, so they will eventually have an intact sphincter complex, and stool will exit from below. A total mesorectal excision means they've taken out the rectum with the tumor and whatever is surrounding the rectum in the mesorectal, deep to the mesorectal fascia. So it's going to include the draining lymph nodes and the mesorectal fascia envelope. You need, depending on who you're reading, 1 to 3 millimeters of distance from either tumor or node to the mesorectal fascia line to make this a successful surgery. And again, these patients will eventually go on to some coloanal or pouch anastomosis. There are a couple things you have to remember. Again, this is a low anterior resection. The tumor is above the sphincter complex. The levator ani are showing where the sphincter complex is. So this portion of the colon is going to be resected. In doing so, the patient is going to have the splenic flexure freed up. If you're going to have a direct coloanal anastomosis, you need a bit of that length to be able to make that anastomosis. So not only will you see post-surgical changes here, but you'll see post-surgical changes in the left upper quadrant possibly. This is a pictorial representation of a pouch creation. They can be very funny in appearance. They aren't sort of classic, this is exactly what one looks like on every exam. So you have to be prepared for unusual appearances of pouches as you image these patients postoperatively. In the patient who has a rectal tumor that is at the sphincter complex or involves and is below the sphincter complex, the patient cannot have a sphincter preserving surgery. So the surgery, and this is an abdominoperineal resection, the surgeons will remove the tumor and block with everything surrounding it and remove the sphincter, and now the patient will require a permanent colostomy for fecal stream. And again, similar diagram, but here you can see that the tumor is at the sphincter complex. It's too low to keep rectal tone and preserve sphincter intact. So all of this will be removed and the patient will have a permanent colostomy. And then finally, when the whole pelvis is involved, the patient will undergo total pelvic exoneration. The tumor is removed with all of the pelvic organs. The patient will have a permanent colostomy and often a urinary diversion as well. These are the more morbid surgeries. These patients have a longer and prolonged course. The early postoperative period, we talk about it. I'm going to give you a definition as far as what the surgeons consider early postoperative period. It's usually within the first 30 days of the surgical procedure, and this is important because this is when adhesive disease and healing begins. Patients will begin to develop adhesive disease within 72 hours of the procedure. And over the next 2 weeks to 2 months, these adhesions will become very thick and vascular, and they will obliterate the natural planes. So it becomes very difficult to operate in that time period. Dr. Paulson said that the surgeons are loath to go in and re-anastomose a pancreatic leak. Our surgeons have a very similar feeling in the colorectal and small bowel arena because at this point these adhesions are very dense. Over past 2 months, the adhesions start to soften up and it becomes easier for the surgeons to go back in and do a resection, but they're very tentative about operating in the early postoperative period. We do a moderate amount of emergent luminal imaging, and we use water-soluble contrast. We're mostly looking for an anastomotic breakdown. I will tell you that the majority of these patients will come to CT first. Non-emergent imaging of the colon or pouch, we do again with water-soluble contrast. We very seldom use barium in this patient population. And again, just like Dr. Cannon said, I can't emphasize enough that getting a scout radiograph over the anastomosis prior to beginning the procedure is essential. We have a lot of patients who come for evaluation of their pouch prior to ileocolonic reanastomosis or an ileostomy takedown, and we are looking for a leak. This patient has a suture line sitting right here that you can very faintly see on the scout radiograph. When you instill contrast, you get this sort of bizarre looking indentation here, and this was originally called a leak down here. This is in fact just a fold within the patient's pouch. The patient did fine, went on to ileostomy takedown, and has done fine since then. If you're imaging the patient with CT, the technique will vary significantly on what you want to know. I don't know how many of you are still using oral contrast routinely. My institution has given up oral contrast in routine imaging of the abdomen and pelvis, but we do like it in the setting of luminal imaging in a patient who are worried about a leak. We prefer to use intravenous contrast. Invariably, 2 to 3 patients a night come down with no oral, no IV, and those are complex cases that always happen after midnight. And then we do like to give an enteric contrast to look for an anastomotic leak. You are going to see pneumoperitoneum. It is some of these patients are going to be, or many of these patients now have their surgical resections laparoscopically, so they will have a little less air than the other patients, but you should be looking for air to resolve between 7 to 10 days post-op. You will also likely see an ileus in these patients immediately post-operatively. And this is expected to resolve in 2 to 3 days after their gut starts to wake up, and sigmoid motility really has a big impact on resolving the physiologic ileus. I will tell you that many institutions, including my own, are doing ERAS surgery, which is early recovery after surgery, so the patients leave the PACU and begin on clears within the 24 hours of their surgery, so they are advancing these patients' diets very quickly, and the patients seem to do very well. Ileus obviously is characterized by diffuse distension of the small bowel and colon, and it generally resolves without anybody getting involved. This is characteristic pneumoperitoneum early on in a patient's postoperative course. The typical post-op changes that are normal are going to be fat stranding in the area of the surgical bed. Just like in all of these entities that we've imaged, there will be fat stranding, a little bit of hemorrhage maybe, and some simple fluid. If you start to see large volumes of fluid or air, you have to start thinking about an anastomotic leak. So this is a classic post-op patient, you can tell the patient's a little malnourished, there's a lot of anasarca, and there's a little bit of uncomplicated free fluid in the resection bed in the patient. This is normal. We see this all the time in the early post-op period. This is another patient with a little bit of simple fluid here. Here's some fat stranding from a right hemicolectomy. We see this all the time. We're all pretty prepared for that. In the pelvis, the imaging characteristics of a post-op pelvis are pretty traditional. Again, you're going to see a small amount of fluid or soft tissue in the presacral space. And the soft tissue is a combination of a lot of things. So number one, if these patients are going to get neoadjuvant chemotherapy or radiation therapy prior to their resection, they may have a bit of fibrosis down there, and that's going to add to some of that soft tissue in the presacral space. It is also a very steep area for the surgeon to dissect, so a lot of the dissection is blind, especially in a steep pelvis. So they're going to scrape a bit off of the presacral space, and that causes some hemorrhage and causes some granulation tissue in there. So that is a routine normal finding. What our job is to watch that finding and make sure it either stays stable or starts to regress. If you get more concave, it looks like it's resolving. It may never resolve, it may stay stable, and that's okay. What you don't want it to do is to start getting convex in borders, because you have to worry about tumor recurrence over time. So this is a patient preoperatively who had a low anterior resection. The tumor is here. And on the post-op image, you can see the evidence that a surgeon has been here, but you can also see a little bit of free fluid and some soft tissue thickening here in the presacral space. We see this all the time. This is a patient who, over time, you can see that soft tissue post-op has started to resolve, and it almost looks like you can't see it at all anymore. And this is the evolution of those changes. Like I said, it may not change, but you don't want it to get worse over time. This is a patient with a post-op hematoma. You can see here preoperatively. Post-op, you've got fluid within the abdomen and pelvis, but you have a nice hematocrit level here that lets you know that this is hemorrhage. We see this in this space. We don't get particularly worried about it. This, however, has a slightly more worrisome picture to it. This was a postoperative abscess in the presacral space. I'm going to talk about abscesses in a minute, but the thick rind around it, the more encapsulated appearance to it, should raise your suspicion of an abscess. Sorry about that. Postoperative complications, big one's going to be an anastomotic leak. The surgeons are always worried about this. There is a range in prevalence in the literature, somewhere between 3 and 10% really. The ileocolic anastomoses are sort of low risk for anastomotic leak, and the highest risk are going to be the coloanal. Again, pretty steep area, kind of blind area for the surgeon, and that places the patient at a slightly higher risk. Other risk factors include morbid obesity, steroid use, anything that will impair healing, so steroids or some other reason to be immune suppressed, malnutrition, so you've got malnutrition and obesity in the same patient, male gender as well, because the pelvis is steeper in the man, so it's a little bit harder anastomosis to perform and they're at higher risk, and then patients who bleed intraoperatively are at higher risk. And if you think about it, the surgeons sort of schematically split these patients into 3 categories. The asymptomatic patient is going to be someone who you happen to pick up a leak on routine follow-up imaging, and they're not bumping their labs, they're not complaining of symptoms. The subtle insidious patient insidious leak is going to be a patient who has failure to thrive in the early post-op window. You just can't get them to tolerate tube feeds. Their temperatures don't go down. They're kind of puny. And then the dramatic early leak, and we've all seen these patients are remarkably unwell when they come down for imaging. When you're looking for a leak, pneumoperitoneum and a fluid collection and extravasation of contrast is where the money is for diagnosing anastomotic leaks. We can see these on both CT and fluoro, but we do, again, mostly CT imaging. This is a patient who had a post-op right hemicolectomy, and you can see a ton of pneumoperitoneum and a ton of free fluid, and this patient was too many days post-op. This patient was about 2 weeks post-op and had an anastomotic leak. This is a serendipitous examination, KUB, after a fluoro examination, you see contrast spilling all throughout the peritoneal cavity. But the majority of the imaging we do looks like this. Here's a patient who had oral contrast, and you can see a frank anastomotic leak in an anatomic structure that doesn't exist. So this is just a fluid cavity that the patient has extravasated into. I promise you this is a different patient. Oral contrast didn't make it down to the anastomosis by the time we scanned the patient, but you can see air, fluid, flocculent debris in something that doesn't look anatomic. This was a patient who had an ileostomy takedown. You can still see the surgical drains, and the patient had a big leak. And these are the ones where hand-wringing begins, because again, they don't like to take patients back in the early postoperative period. It's a very hard abdomen to operate in, so some of our surgeons like to temporize these patients with drainage. This is a patient with a postoperative fistula, pre-op. This is post-op, and you can see enhancing margins of this fluid collection. This was an abscess, and my group does a ton of percutaneous drainage of these things. You can see our catheter in place, and the abscess has resolved, but the patient continued to come back with collections after the tube was removed. This is him at a different point in time. You can see that we are imaging the anastomosis, and this cavity freely fills with a drain in place. So this is a persistent fistula from a fluid collection. Abscesses are like abscesses everywhere. So they're well circumscribed, the margins will peripherally enhance, they may have flocculent air within it, and again, we routinely manage these with percutaneous drainage. This is a patient with an abscess in the right resection bed after a right hemicolectomy, and we put a drain in that. The answer is always we can put a drain in that, so we do. This is a patient who had an APR, so she this patient should have nothing in this space, and you can see this well circumscribed encapsulated collection here with air within it. This was an abscess and it was drained. Small bowel obstruction in the early postoperative period. So first I'm going to talk about all comers. Typically these patients will present within the first 2 years, have colonic surgery. Within the first 2 years of surgery, 14% of patients will have a small bowel obstruction, which is a pretty amazing statistic if you think of all the people who have colonic resection, those who have it for diverticulitis and all sorts of other reasons. Most of these patients will not require surgery. In the early small bowel obstruction, and this is in that early postoperative period, we're talking about a couple days post-op, variable risk, 1 to 10% in the literature of people who present in the early post-op period. This is before they've been discharged even. And this is, again, a very dangerous window for reoperation. So these patients are often managed with nasogastric tubes for a prolonged period of time. And if they don't get better after 2 weeks of nasogastric decompression, then the surgeon is forced to go back operatively and take care of the patient. The one thing you want to exclude is that the patient has herniated bowel at a laparoscopic port site, because these do need to be repaired surgically. And this is a patient very soon after the original surgery, and you can see this is status post right hemicolectomy, and you've got a relatively high-grade small bowel obstruction. This patient did fine with nasogastric decompression. And then finally, our role in the postoperative patient is not only to look for complications, but to look for recurrence. And in the setting of colon cancer, tumors can recur extraluminally or intraluminally at the anastomosis. And then because of the unique nature of colon cancer and its proclivity to go both to the liver and lung, these patients will get a chest, abdomen, pelvis. In fact, the American Society for Clinical Oncology recommends a chest, abdomen, pelvis for the first 3 years postoperatively, and always include the chest because the lung is an equivalent anastomotic bed or a metastasis bed to the liver. So you don't want to exclude the chest when you're re-imaging these patients. The lung metastases, if singular, are more easily resectable than liver resections, as we learned. And so you really want to make sure you're very vigilant about this patient population. This is the National Comprehensive Cancer Network. If you ever wonder what their guidelines are, you can log on for free and become a member. And this is their guidelines for surveillance: chest, abdomen, pelvis annually for 3 to 5 years in patients for high risk for recurrence. PET scan is not routinely recommended. We've seen a strict a very steep downturn in our PET imaging of this patient population, but we do a ton of CT imaging of these patients. MR is not our screening modality of choice. We are pretty committed to the CT form, and that is the recommended modality by the societies referring their patients to us. Again, variable appearance of colorectal metastases. You can have right along the anastomosis. This is an exophytic anastomosis. This is a patient who developed something in the presacral space in that bed. This is a patient who I'm not sure I would have picked up on the CT portion of this exam. It just became a little thickened just above the anastomotic margin, and this was a colorectal recurrence. This is a patient with a lung metastasis. They tend to be round and well circumscribed. And then this is the one that scares me. This is a patient back when we were doing more PET who had what looks like a sort of ill-defined low attenuation area just in the area you'd expect diaphragmatic slips, though. So very often you see these and you sort of excuse them for pieces, volume averaging of the diaphragm, but this actually ended up being a metastasis very high in the liver. This is a patient, again, we've got some PET imaging. Chronology is really important. We love old imaging because it's very helpful to watch tumor beds. This is post-resection, and you can see at the time, immediately post-op, patient had a normal adrenal. Now the patient no longer has a normal adrenal, and this was an adrenal metastasis. So chronology and being able to go back multiple prior imaging studies is really very helpful. So thank you, everybody. Hopefully in this time we've reviewed the anatomy and the surgical procedures, and I think all the speakers are now available for questions. If there are questions from the audience, we can do this informally or formally. Thank you.
Hi, this is Pam Johnson. Today I will be discussing pancreatic surgery with emphasis on pre- and post-operative CT imaging. Surgical resection is necessary for the definitive treatment of pancreatic cancer regardless of whether it's adenocarcinoma or malignant neuroendocrine tumor. CT is essential for pre- and post-operative management of these patients, and we've advanced beyond lesion detection and determination of resectability as a result of the advances in CT technology that have improved resolution. Additionally, owing to newer surgical techniques, the role of CT has expanded. In this talk, I'm going to review the role of CT for identification of pancreatic tumors, determining resectability, surgical procedure planning, identifying normal postoperative findings versus postoperative complications, and the post-treatment surveillance for recurrent tumor. Beginning with identification of pancreatic tumors, we have a number of different imaging modalities available. Literature has suggested, this is an older paper from 2005, that CT is superior to MRI and transabdominal ultrasound. MR has certain advantages, which include the absence of radiation exposure and the fact that scans can be performed without administration of iodinated contrast. As we all know, endoscopic ultrasound is an invasive procedure, and PET-CT has a limited role in the imaging of these patients that I will discuss a little bit later. This is a newer paper published in 2011 in Radiology that compared 64-slice CT to 3 Tesla MRI, and I think it's really essential when you're reviewing articles to look at the technology that was used, because there are big differences between 4-slice, 16-slice, and even 64-slice and beyond, with big improvements in spatial, temporal, and contrast resolution. So results that are pertinent to today are those as reported in this paper using the most current technology for both CT and MR. What they found in this study was that there was no significant difference between CT and MR for tumor detection in terms of specificity and sensitivity, and there was no difference in terms of the ability to determine which patients were resectable when comparing CT and MR. Here's a separate paper that compares CT and endoscopic ultrasound in patients with neuroendocrine tumors. This is also a recently published paper, but important to recognize that they had 217 patients who were imaged between 1984 and 2009, which reflects a wide range of different CT technology over the years. The results from this paper showed that endoscopic ultrasound was more sensitive than CT, particularly for insulinoma. And endoscopic ultrasound identified 20 out of 22 CT-negative tumors. However, important to note, they then stratified the cases by CT technology, and comparison shows that I only listed the 4 and 16 and 64 slice CT results, but as you can see, as we got into more advanced CT scanners with the 16 and 64 slice, the sensitivity for CT was 89%, very similar to the endoscopic ultrasound. With respect to another paper comparing CT and endoscopic ultrasound in 62 patients with pancreatic cancer, this is a paper from 2004, CT had the highest accuracy among multiple different imaging modalities, including MRI, angiography, and endoscopic ultrasound. CT was most accurate for assessing the extent of primary tumor, locoregional extension, vascular invasion, distant metastases, TNM staging, and resectability. Endoscopic ultrasound in this series was more accurate for delineating the size of the tumor and for identifying lymph node involvement. So let's take a moment now and discuss PET-CT, because more patients are being imaged with PET-CT. Particularly, we've seen cases at follow-up trying to determine whether there's recurrent disease. This is a study of 56 patients who had a negative PET-CT, and it turned out that of these patients, 25% of them actually had malignancy, including adenocarcinoma in an IPMN, ductal adenocarcinoma, pancreatic neuroendocrine tumors, and ampullary cancer. So from this paper, we learned that PET-CT has a negative predictive value of 75%. And it's important to recognize that not all tumors will be identified. There are tumor markers that can be measured for both diagnosis of cancer at the onset and for identification of recurrence. These include CA 19.9, which has been used widely. More recently, there's CA 242. Studies suggest that this may be better than CA 19.9. It has a sensitivity and specificity for identifying pancreatic cancer of 60%. Some studies have shown that there are lower survival rates if the patient has a positive CA 242, and the patients with levels greater than 100 have a poorer outcome among those with unresectable disease. So that's a basic review of the different imaging modalities for identifying pancreatic tumors. I'd like to move on to a discussion of determining resectability in these patients. Overall survival for patients with pancreatic cancer is 4% at 5 years. The unresectable patients have survival rates of less than 1%. A certain percentage, up to 20%, are resectable, and among these patients, the survival at 5 years can be as high as 20%. So it's very important to identify the patients that are candidates for surgical resection. How accurate is CT? This is a paper, a review article over a 10-year period that showed that the negative predictive value was 87% for resectability, and the accuracy in predicting resectability can be as high as 95%. It's an excellent imaging tool. We have a very large population of patients who come to Hopkins with pancreatic cancer. CT is our primary imaging modality. In 1997, it was shown in this paper in AJR the importance of performing CT angiography in conjunction with axial CT, because this study showed an increase from 70% to 96% for negative predictive value to determine resectable tumor when CT angiography was used in comparison to just axial images alone. Here at Hopkins, we do standard dual phase interpretation with axial and MPRs, and in addition, each of these patients undergoes dedicated 3D rendering with volume rendering, MIP, and interactive MPR. We feel that this is the optimal way to evaluate these patients, both preoperatively and postoperatively. In terms of resectability, this was an older paper showing that CT and MR are similar in sensitivity, which has been substantiated by the more recent paper that I discussed earlier, published in 2011. In comparing CT with endoscopic ultrasound for resectability, this study showed that both modalities were correct in more than half of the cases. There were some cases where CT was correct and endoscopic ultrasound was not, but there were also a small percentage of cases where only endoscopic ultrasound was correct. The big question today is whether it's not just simply whether the patient is resectable or non-resectable. We now have a category of borderline resectable, and it's important to recognize these patients because they have a different algorithm. So just a quick quiz question. Which of the following patients is potentially resectable? A patient with celiac encasement by a pancreatic body mass, a patient with SMA encasement by a pancreatic head mass, short segment SMV encasement at the confluence, no vascular encasement but isolated omental implant, or A and C. And the answer at the present time in a high-volume center like ours is that patient A, who has celiac encasement by a pancreatic body mass, and patient C with a short segment SMV encasement at the confluence are potentially resectable. So let's discuss how we define non-resectability. This includes patients with superior mesenteric artery or celiac artery encasement, which on CT is identified by more than 50% of tumor surrounding more than 50% of the vessel perimeter. Secondary signs include deformation of the vessel, such as beading and narrowing. Unresectable portal or superior mesenteric vein involvement is non-resectability. Patients with distant metastases, either liver or lung, and peritoneal spread of disease. These are not surgical candidates. So what is resectable venous involvement? So resectable venous involvement is venous involvement that can be treated by resection and reconstruction of the portal vein or superior mesenteric vein segment. Ideally, the involved segment is downstream from the entry of the jejunal branches, which means cephalid, and the segment is less than 2 centimeters in length. There are some different definitions of borderline resectability depending on the institution. The NCCN defines this as severe impingement of the portal or superior mesenteric vein, less than 180-degree involvement of the superior mesenteric artery, reconstructible encasement of the hepatic artery, and a short segment reconstructible occlusion of the superior mesenteric vein. MD Anderson has defined borderline resectability as abutment or encasement of a short segment of the hepatic artery, less than 180-degree abutment of the celiac and superior mesenteric arteries, and reconstructible portal vein, superior mesenteric vein involvement. Additionally published is a consensus statement pertaining to borderline resectability of the portal vein SMV. This includes tumor-associated deformity, less than 180 degrees abutment, and reconstructible short segment occlusion. This photo is from a paper that was published in 1992, and I think it's interesting to note that it may prove that the configuration of the venous involvement has some predictive value, and specifically patients who have abnormality that is only involving one side of the portal vein have a better outcome than those who have circumferential involvement by tumor. So I think that these are important things to include in your dictation to provide. It's essential to provide a detailed dictation describing the tumor, describing the relationship to the arteries and veins, recognizing that different institutions have different thresholds for resectability, and tailoring your report to your surgeon's practice, so to provide these patients with the best of possible outcomes in terms of those who may be resectable and amenable to venous reconstruction. So before I stop, I'd like to review a few additional things that we should be looking at on CT that we don't talk about very often, but which are important for procedure planning. Beginning with vascular anomalies, vascular pathology, evaluation of lymph nodes, and the time interval between CT and surgery. After this, I'm going to discuss the different surgical procedures that are performed at present. So it's very important to look closely at the celiac and the superior mesenteric artery, not just for tumor involvement, but for the presence of vascular anomalies or the presence of additional pathology not related to the tumor. Significant vascular anomalies that may complicate surgery include the presence of a replaced common hepatic artery from the superior mesenteric artery. In these patients, ligation can result in ischemia of the choledochojejunostomy and a bile leak. Patients who have a celiomesenteric trunk or a common origin of the celiac and SMA, this can be problematic because clamping can result in ischemia. And patients who have celiac stenosis, whether it's due to atherosclerosis or median arcuate ligament syndrome. So in terms of celiac stenosis, this is not uncommon. It may be present in as many as 25% of the population. It's usually caused by median arcuate ligament syndrome or atherosclerosis. And this becomes problematic during pancreatic duodenectomy because the blood supply to the pancreas, stomach, spleen, and liver is sustained by pancreatic duodenal collaterals, which will be ligated during the surgery. If this is identified preoperatively, the patient may actually undergo stenting or bypass. If it is not identified preoperatively, the surgeon detects this by clamping the gastroduodenal artery. If there's significant celiac stenosis, the patient will develop hepatic and gastric ischemia at this point. So really, ideally, we'd like to identify these patients prior to their surgery, underscoring the importance of looking at those sagittal reconstructions to identify celiac and superior mesenteric artery stenosis that's going to impact the surgical procedure. With respect to identifying metastatic lymph nodes, here's a paper where they had 119 patients with adenocarcinoma. They defined nodal involvement as a long axis diameter of greater than 10 millimeters. And 13 patients were suspected to have metastases by imaging. All of them were negative at pathology. The 6 patients who did have metastatic lymph node involvement all had negative preoperative imaging. So take-home point here is that we have a very difficult time in identifying metastatic lymph nodes in these patients. One final thing to consider, and that is the time interval between the CT scan and the patient's surgery. This is a larger study of 487 patients. 18% of them had unanticipated metastatic disease at surgery. The study showed that there was no significant difference if the patient's scan was performed at a university hospital or an outside hospital, but there was a difference in the rate of unanticipated metastatic disease depending on the time from the CT to the surgery. So if a patient's scan was performed between 14 and 20 days prior to surgery, the rate of unanticipated metastatic disease was 12%. Patients whose scans were performed 35 to 41 days before the surgery, 35% of them had unanticipated metastatic disease. So very important to recognize that a current CT is necessary to identify the patients that are really surgically resectable. So I think I will stop there, and when I return, we're going to discuss the currently used surgical techniques here at Hopkins, the different range of surgeries, indications. This will be followed by a review of normal postoperative findings and the postoperative complications in these patients. Thank you very much. Hi, this is Pam Johnson, continuing my discussion on pancreatic surgery. So I would like to review the currently used surgical techniques here at Hopkins, which include the classic Whipple procedure, pylorus-sparing Whipple, central pancreatectomy, distal pancreatectomy, the Appleby procedure, and enucleation. Many of these are being performed both as open surgeries and laparoscopically. So the most widely known is the Whipple procedure, which is either the standard pancreaticoduodenectomy, which includes creation of a hepaticojejunostomy, gastrojejunostomy, and a pancreaticojejunostomy. And in some patients who are amenable, the procedure can be performed sparing the pylorus. So here's a patient who was deemed a candidate for a Whipple procedure, 55-year-old woman with recurrent pancreatitis, who was found to have an underlying moderately differentiated adenocarcinoma. As you can see, this is well removed from the vasculature without any evidence of encasement. There was no evidence of metastatic disease. She underwent a pylorus-preserving pancreaticoduodenectomy. So I'd like to review these surgical techniques, amazing illustrations from a paper that we published with the surgeons here at Hopkins in AJR, showing the Whipple procedure as it is performed surgically, beginning with dissection of the stomach. It is at this point in the surgery that the surgeon determines whether the patient is amenable to a pylorus-sparing procedure. Following this resection, then the pancreas is resected. And then subsequently, the 3 anastomoses are created, beginning with the pancreaticojejunostomy. Several centimeters beyond this, the surgeon creates a hepaticojejunostomy, and then at a longer distance, either a duodenojejunostomy or a gastrojejunostomy. So this is the configuration that you should recognize in your mind when you're evaluating these patients postoperatively on CT. Moving along to the central pancreatectomy, here's a patient, 71-year-old man with a cystic pancreatic lesion. A patient like this is a candidate for a central pancreatectomy. He underwent pancreatectomy and pancreaticojejunostomy and was found to have IPMN with moderate dysplasia. In this procedure, just the central portion of the pancreas is resected, and the pancreatic neck and anastomosis of the tail are oversewn into either the stomach or a Roux-en-Y limb of jejunum. Important to recognize that because there are 2 pancreatic suture lines, this procedure carries a high risk of pancreatic fistula. The distal pancreatectomy. These are patients who have tumors in the body and tail of the pancreas. Here's a 49-year-old man with moderately differentiated adenocarcinoma of the pancreatic tail who was treated with distal pancreatectomy and splenectomy. In this surgery, you can see that the resection is performed up at the junction of the body and neck of the pancreas, and in addition to the pancreatic body and tail, the spleen is resected. So I'd like to review with you the Appleby procedure. This is a newer procedure for patients who have vascular involvement that was traditionally deemed unresectable. Here's a man, 64-year-old, with ductal adenocarcinoma of the pancreatic body. He underwent distal pancreatectomy, splenectomy, hepatic artery, and celiac artery resection. And in this surgery, what the surgeon does is resects the celiac artery. Please note that this is a mass in the pancreatic body, not in the pancreatic head. But they resect the pancreatic body and tail, they resect the celiac artery, and the gastroduodenal artery supplies the hepatic artery from the superior mesenteric artery. So again, this will be in a patient essential to recognize any disease of the SMA preoperatively. So just a quick review. It begins as a standard distal pancreatectomy. The GDA is identified, and the surgeon test clamps the common hepatic artery. Palpation of the pulse in the common hepatic artery confirms the retrograde flow and adequate hepatic perfusion despite resection of the celiac artery. An additional surgical procedure that can be performed in very select cases is enucleation. This is a 52-year-old woman with a small hypervascular peripancreatic nodule that was suspected to be an insulinoma based on clinical symptoms. So she underwent exploratory laparoscopy and excision, which disclosed an enlarged peripancreatic node. And as shown in this illustration, the surgeon can perform an enucleation of a small lesion such as this but only in select cases. This would not be the surgery for a patient with a cancer. So following surgery, the role of CT is to identify postoperative complications. So it's essential to recognize that there are normal findings on CT which should not be confused for complications. These include pneumobilia, mesenteric inflammation, and the presence of small nodes. You have to recognize the anastomoses. Here's a nice example of the gastrojejunal anastomosis. There is commonly gastrojejunal edema at the anastomosis. This can contribute to delayed gastric emptying and gastric outlet obstruction, one of the most common complications postoperatively in these patients. It's essential not to confuse unopacified bowel for tumor. Here's a patient, the image on the left, there's what looks like soft tissue anterior to the liver, but as you can see in the image on the right, this opacifies with oral contrast and is a bowel loop. This is part of the jejunal anastomosis. It is common to have lymph nodes postoperatively. In this patient, the baseline post-op shows nodes adjacent to the portal vein, which, as you can see on the 7-month follow-up, have decreased in size and were not evidence of residual or recurrent disease. Postoperative stranding is very common. Here's the baseline post-op scan showing stranding around the superior mesenteric artery and vein, which had decreased at the 7th-month follow-up scan. I think it's important to take a good look here at the SMV. On the initial scan, there's some flattening of the posterior wall. On the follow-up scan, you can see that the vein is round. And what these findings reflect is resolving postoperative edema. This same patient who had stranding and adenopathy actually recurred in the liver. The tumor recurred in the liver at a later date, which supports the fact that the initial findings were benign and not evidence of recurrent or residual disease. In about half of the patients, the surgeon will place a pancreatic duct stent, and in some cases, this will migrate, which is really not of any clinical significance, but important for the patient to recognize that the stent is going to be passed. Patients will undergo chemotherapy and radiation, and it's important to recognize findings on CT that reflect these therapies. Radiation causes mesenteric inflammation and stranding. It can cause geographic fatty infiltration of the liver, atrophy of the medial kidney if it is in the radiation port, and edema of the gastrojejunectomy. Many patients develop chemotherapy-induced hepatic steatosis. So a couple examples. Here's some stranding in the region of the gastrojejunectomy induced by radiation. Here's a patient with atrophy of the medial right kidney because it is in the radiation port. And here's a patient with chemotherapy-induced hepatic steatosis. In terms of postoperative imaging for identifying complications, the most common complication, as I mentioned, is delayed gastric emptying, which can occur in up to approximately a quarter of the patients. Patients are at risk for developing a pancreatic fistula, especially following central pancreatectomy. This is detected clinically by identifying more than 50 milliliters of amylase-rich fluid within the drainage. On CT, you may see a large collection or the presence of fat necrosis. Other complications include wound infection or dehiscence. Here's an example of a patient with delayed gastric emptying. You can see by the retained food in the stomach. And here's a patient who was sent from the outside with the diagnosis of a pseudocyst. As we can see, there is some sort of encapsulated collection in the right upper quadrant, but it is not fluid density. In fact, it was fat density, and this is fat necrosis that reflects a pancreatic duct leak. Essential to recognize, this is not something that's going to be amenable to drainage, and it's indicative of an underlying pancreatic duct leak. Other complications include anastomotic breakdown, which can result in peritonitis, pancreatitis, common bile duct stricture, development of collections including biloma and abscess. And here's a patient with postoperative pancreatitis and a perihepatic collection. Here's a patient who developed a common bile duct stricture. You can see that the duct is dilated but tapers with no mass distally, and this was just caused by stricturing. Here's a paper from radiographics showing the difference between postoperative collection on the left and abscess on the right with peripheral enhancement and both fluid and air within the collections. Postoperative hemorrhage is one of the worst complications. It occurs in less than 10% of patients, but it accounts for 38% of deaths, according to a paper published in AJR. This can be caused by celiac axis erosion, splenic artery erosion, aneurysm of the inferior pancreaticoduodenal artery, or other aneurysms, pseudoaneurysms. I show this one case from the paper because it teaches an important point, and that is that pseudoaneurysms may not be apparent on the arterial acquisition. In some cases, they do not fill until the venous acquisition. We routinely perform dual phase imaging on these patients. Pseudoaneurysm is something that you really do not want to miss. And in this case, it's a small pseudoaneurysm. They showed the venous phase image on the left where the aneurysm enhanced, and it was not identified on the arterial phase. Here's a case from our institution just showing the similar teaching point. This is much larger and clearly apparent on the arterial phase, but look at the level of enhancement on the arterial phase to the venous phase. There's much greater enhancement on the venous phase acquisition. So keep in mind, pseudoaneurysms may become increasingly apparent on the venous phase. Other complications, vascular complications, include portal vein thrombosis and splenic infarct. So the final role of CT in these patients that I'd like to review is post-treatment surveillance for recurrence. Here's a paper published in 1997 that showed that patients with positive surgical margins have earlier recurrence. It most commonly occurred in the pancreatic bed, but additionally it can arise in the liver in the forms of hepatic metastases, and in 20% of patients, recurrence was in both locations. So this is really where we're looking carefully, in the pancreatic resection site, within the liver, and also within the omentum and the peritoneal cavity. In the pancreatic bed, findings which suggest the presence of recurrence are development of new soft tissue stranding or mass, new narrowing of the portal vein SMV. Important to recognize that radiation can cause stranding and can even cause narrowing of the vein. So you must correlate with whether the patient is currently undergoing radiation and make your interpretation accordingly. In questionable cases, we perform a short-term follow-up. I'd like to show this case showing some very subtle findings that were reflective of disease recurrence. In the image on the left, you can see that the SMV has a very rounded contour. In the image on the right, there is a new subtle narrowing in the transverse diameter of the vein. This is one of the earliest findings of recurrent tumor. It can, as I mentioned earlier, it can also be secondary to radiation. In the same patient, if we look coronally, we see the same finding with narrowing of the confluence that is new from the prior examination. So this was worrisome. The patient actually did have two additional findings, including an enlarging retroperitoneal lymph node and a new lung nodule. So the constellation of findings was highly suspicious for recurrent disease. So in this more recent paper from the World Journal of Gastroenterology, mean recurrence occurred at 12.9 months and was most commonly local in the pancreatic resection site, but also was identified within lymph nodes, liver, and also in the form of peritoneal carcinomatosis. So as I emphasized previously, we look in the pancreatic resection site, look carefully in the liver, and then carefully inspect the omentum and the peritoneal cavity for metastatic disease. Local recurrence specifically was most commonly in the region of the superior mesenteric artery, but was also identified between the celiac portal vein and IVC, between the SMA portal vein and IVC, and in the region of the hepatic artery. Lymph node recurrence was identified most commonly in the mesenteric root and in the left para-aortic region. And that patient that I showed you previously with the new narrowing of the portal confluence also had this lymph node that had enlarged slightly, and you really can see the evidence of enlargement as new flattening of the inferior vena cava posterior to the node, very worrisome for tumor recurrence. Another method of identifying recurrence is measuring the CA 19.9. In this paper from 1997, it was shown that the CA 19.9 level is much lower in the setting of liver recurrence as compared to local pancreatic bed resection recurrence. And in correlating the CT findings with the CA 19.9 level, 41% of patients had an elevated CA 19.9 before findings were apparent on the CT between 2 and 9 months prior to the CT being abnormal. 47% had an elevated CA 19.9 concurrent with new CT findings indicating recurrent tumor, and 12% had a normal CA 19.9 in the presence of CT evidence of recurrence. So in conclusion, CT has really expanded as an essential component for both preoperative and postoperative management of these patients. Be aware of the new surgical procedures when you're dictating your findings, when you're doing your initial interpretations, because what was traditionally deemed unresectable is no longer. It may be borderline resectable. And following surgery, it's important to recognize normal postoperative findings and distinguish them from complications. On serial imaging postoperatively, look carefully for recurrence in the patterns that I've described here. So thank you very much and have a great day.
This is actually kind of a hard talk for me to do because as opposed to the other surgeons on the podium, I never have complications. But I will certainly try my best to do what at least I've heard happens. Okay.
I'm here to keep him honest.
Yes, exactly. I have no disclosures. So I guess the first thing is I'm going to be talking about postoperative care. And I guess the real question is, why should you guys care? I mean, what's the difference? We know how to take care of this. And I think it's important because as gastroenterologists, you should have a fundamental understanding of what we do in the operating room. Quite frankly, most of the acute complications that we see after the surgery like this involves the bowel, which is your purview. I think it's important for continuity care, not only because you're being a good doctor, but patients actually like you to be there. Patients who you've been managing for years on medication who all of a sudden need surgery, they almost sense that they've been abandoned, which rightly you can argue if it's right or wrong, but they sense that they've been abandoned when you say, hey, by the way, go see Dr. Fleshner and come see me after you're done. I don't think that's really good. And I think the other thing, which maybe is the more important reason, or most important reason, is that you can appreciate the adverse effects of preoperative medications that many of you use in our patients that we actually have to operate on. And I think Neil showed you some data. This is paralleling his data. We looked at preoperative medication use in our patient cohort, and you can see biologic use in orange has increased significantly, but yet there's still a large number of patients who still are on steroids and immunomodulators at the time of surgery. So the use of medications has not stopped, and many of these patients who we see at the time of surgery are on either some, or as you can see in the orange on the right, a lot of medications when they come to surgery. So when we talk about early complications, we're talking generally within 30 days of surgery, and they include the complications shown here. So we'll go through some of these in some detail, but not too much. Wound infection is one of the most common ones. It occurs in about 10% of reported cases, no doubt related to operating on a contaminated organ. The incidence seems to be lower with the use of fan and seal incisions. That's why you're seeing a lot of us using fan and seal incisions that are minimally invasive surgery, not only because of cosmesis, but also also because of less pain, but also there seems to be a lower incidence of wound infections. In the operating room, we use these things called wound protectors, which look like almost saran wrap that covers the wound to try to minimize the incidence of infection, and the perioperative use of IV antibiotics. Now, many of these patients, despite all of this, still get wound infections. As I said, about 10% of cases. When you see a patient in the morning, let's say before the surgeon's been there, and you see a red raised area, until proven otherwise, that's an infection, okay? There is no role, repeat the word no role, for IV antibiotics or any antibiotics in that patient. That patient needs the wound opened up. That's the treatment for a wound infection, okay? And there's no role for culture. The only time you sometimes do that if you're considering, let's say, a diabetic, or if you think a patient has a MRSA, whatever. But in general, particularly when you're working on the GI tract, there is little, if any, role for antibiotics or culture. That's open incision and drainage of an abscess, basically a wound infection. The other thing that's another complication that's fairly common is dehydration after ileal pouch surgery. We've been seeing this more and more. I don't know what the other experiences the surgeons have been. And this is what happens. Let's say the patient has a 3-stage procedure. So initially you take the colon out, they end up with a terminal ileostomy. They go home, they have their entire small bowel in continuity, and they generally do okay, although they can become dehydrated and have nausea and ileus. We'll talk about that in a minute. But they're generally able to hydrate themselves. They then come back for their second of 3-stage procedure where you're doing the J-pouch. The J-pouch then uses some of the small bowel, the terminal ileum, for example. It reaches into the pelvis, but then you bring up an ileostomy above that, and now you've defunctionalized all the bowel below that. And many of these patients now are coming in with dehydration. It's one of the most common reasons for readmission to hospital, which CMS considers a sense of quality care. As mentioned, it results from the proximal stoma replacement, a lack of a colon. This is very important that you educate the patient on what they need to do. They cannot just go home and drink pure water. They are going to have electrolyte abnormalities like you would not believe. They have to be told to drink lots of salty fluid, Powerade, Gatorade, etc., salt their food like crazy, things that their doctors have told them never to do, temporarily until the ileostomy itself gets reversed, usually in about 2 to 3 months. And there is some very good evidence that aggressive therapy by an RN with post-op phone calls to the house, making sure they're urinating well, that the urine is not too concentrated, can reduce the incidence of significant dehydration and obviously therefore readmission. Now, ileus. Ileus is the killer of all abdominal surgery. You could do the world's best surgery, you could sew an anastomosis together for 9 hours and it could look absolutely perfect, and you get ileus and it screws everything up. And we have no way to absolutely prevent it. Obviously, many of you have seen these patients, they're doing well and all of a sudden they get nausea, they don't feel well, they start vomiting. And there's really, the way to conceptualize this is that there's 2 different forms of ileus. There's the early ileus that generally occurs within 4 to 5 days post-op, when the patient initially tolerates food and all of a sudden they get these symptoms. These patients, you stop the diet, you put them on IV fluids. If they continue to vomit, you put an NG tube. There is little or any role for a KUB, okay? We always teach our surgical residents that you do test if it's going to change the management of the patient. There is nothing on a KUB except for maybe if you're suspecting a gastric dilatation that's going to change what you're doing. So there's really little, if any, role for a KUB. And you noticed that I wrote down here that it seems that early ileus may be reduced with early advancement of a regular diet. So you're looking at me and you say, what's going on with this? Well, you know, when I was Gil's age, okay, what happened is that I was taught in my surgical residency that you never wanted to feed the patient because you were thought that it was going to cause more abdominal distension, more nausea, more vomiting. They're going to get bloated, the wound's going to dehisce, and they're going to aspirate and die. That's what I was taught. And there were also concerns that the food particles would come down to the anastomosis and break down the anastomosis and you get increased leaks. That's all nonsense, okay? That does not happen. And what we did a couple years ago is we actually looked at this scientifically and we did a prospective randomized trial. So what we did is we took patients after major colorectal surgery and we included, you can see 104 patients, which by the way for a surgical study is pretty high. I understand it's not the 6,000 patients you guys get in medical studies. Okay, study cohort of 104 patients, approximately half of them got a clear liquid diet, approximately half of them got a low residue diet on day 1 after surgery. Look at the incidence of vomiting. Incidence of vomiting was higher with the clear liquid diet on post-op day 1, significantly higher. And even on post-op day 2, even though it didn't reach statistically significant, you can see it was still twice as high. Look at the incidence of nausea. This is just a Likert scale to get a sense of how nauseous they were. They were more nauseous on a clear liquid diet. Antiemetic use for days, okay? Less with a low residue diet. I know this sounds like, what am I talking about? NG tube insertion, this concern that you somehow or another were going to cause, nausea and vomiting, they were going to vomit and you're going to have to put NG tubes in. No difference. And look at the length of stay. 2 days less with an intervention that costs nothing, okay? Prospective randomized trial. And in fact, this is the data that is suggested to me, and it makes sense. It's like a use it or lose it phenomenon. Feed the patient. Obviously, if the patients don't want to eat, they'll tell you. Many patients in the morning, they just don't want to eat. That's okay. But try to feed your patient if you can. Okay, and by doing that, you can reduce the incidence of ileus. The other type of ileus which we see is the more ominous form, is the one where the patient initially is doing well, goes home, and then comes back, let's say 5 to 10 days later. That's when you start thinking of a surgical complication, a leak. adhesive small bowel obstruction. That's where you start getting imaging studies, KUBs, CAT scans, gastrographic enemas, et cetera, labs if you need it. So there are important roles for imaging in that situation with a post-op ileus. What about an anastomotic leak? An anastomotic leak is the equivalent to a surgeon to your colonoscopic perforation. That feeling that you get, hopefully many of you have not had that, but I'm sure all of you had if you do enough scoping. When you see the mesenteric fat during a colonoscopy and your heart drops to the floor, that's the feeling that every single surgeon hopefully should still get when we see an anastomotic leak. It's the worst thing we can do, we think. But 5% incidence, usually higher with a distant location in the bowel, usually occurs within the first week. Not all of those patients, however, need to go to surgery. If they're stable, they can be treated non-operatively with CT drainage if they have an associated abscess. They may end up with a fistula, but that's a calculated risk. If a patient's unstable, do not fool around with just watching the patient. That patient needs to go to the operating room. You need to be aggressive with that patient and resect the anastomosis, potentially do a temporary stoma. The thing you do not do is just put a stitch into the stoma and go home, okay? There's a very important expression we talk about in colorectal surgery, and that is, don't screw up the screw up, okay? So when you have an anastomotic leak, the so-called screw up, be very aggressive and smart in how you're treating that patient. Don't start being fancy, okay? You have a patient behind it that needs to get better. What about intra-abdominal abscesses? Fever, pain, and what I like to call the dwindles. Patient goes home, they're just not doing well. They don't eat, they're losing weight. Doc, I don't feel well. I'm having some pain, I just don't feel well. That's the clinical suspicion that they should have an intra-abdominal abscess. You can get a white count if you want, that's fine, but most of the time it relies on imaging, usually CT scans. It's okay to eat. Obviously, you treat them with IV antibiotics. Obviously, the CT scan will tell you not only if there's an abscess, it'll also give you some idea of the size of the abscess. Usually the small ones are easily treated with antibiotics alone. They rarely require IR drainage. Quite frankly, our IR docs can't even put a pigtail catheter into a relatively small abscess. The larger ones, pigtail catheter drainage is very effective for that. The drain stays usually until the purulence and or the fluid abates. And there's, at least in the surgical literature, in my practice, there's no need for follow-up imaging so long as the patient continues to improve. If the patient doesn't improve, you can do that. That's fine. What about a pelvic abscess? It's a little bit different than intra-abdominal abscess. It occurs after you've seen what Dr. Ramsey showed you, ileal pouch anal anastomosis. You've seen them even after low anterior sections for cancer, et cetera. And the key symptom to suspect a pelvic abscess is a patient says, "Doc, I can't sit. It hurts." They don't have fever usually, although they can. But if someone says to you 3 weeks down the line, "Doc, every time I'm sitting, this is hurting," until proven otherwise, that patient has a pelvic abscess. And the reason it's important to know about and know about early is that it does affect long-term function of whatever anastomosis you're doing, and therefore you should be aggressive to try to find out what that is with imaging. If it's relatively small, many cases, again, with antibiotics will work, but sometimes you need CT-guided drainage. The problem with CT-guided drainage and pelvic abscesses is they have to go through the gluteal muscle, and they're very uncomfortable for patients, but they're also very effective. And sometimes, depending on the nature of the abscess, particularly if it's communicating with the bowel, it does require an examination under anesthesia with not catheter drainage by IR, but actually transanal drainage that we do, obviously, through the anus surgically. Now, what about DVT? Neil was mentioning something about DVT and PICC lines in patients who were anticipating surgery. What about post-op? Well, IBD patients are also at high risk for DVT post-op. We know they're a hypercoagulable state IBD. Many of the surgeries are done in the patients with lithotomy position, which is a known risk for DVT, and many of these surgeries are very long. And some of the preventative measures that you can take are early ambulation, SCDs, that all of us know the squeegee things, and low-dose sub-Q heparin. One of the controversial things, though, is when do you give the sub-Q heparin? Some guidelines recommend that the sub-Q heparin should be given prior to surgery. Other guidelines recommend that you can be given any time within 23 hours of the surgery, and no one knows which one's the best. There are concerns that if you give pre-op sub-Q heparin, obviously at the time of the surgery, that somehow or another the patient's going to bleed in the operating room and you're going to have more bleeding. On the other hand, you may not want to do it post-op because many of the clots form on the table, particularly if they're in lithotomy position. If you don't have any protection with heparin at that point, you might not be doing the patient a favor. And the other thing that's been very interesting is, because we know these patients are hypercoagulable, how do we know these patients aren't coming in with a clot already? And is it possible that they actually have an occult clot And therefore, that would lead to a falsely elevated postoperative DVT rate. So what do we do? Just like we did with the early diet study, let's do a randomized trial. So what we did is we took patients, and half of them, all patients who came in for major colorectal surgery had a duplex scan in pre-op. Okay? The hospital was very supportive of this. Then they were randomized at that point to either preoperative heparin or postoperative heparin. And then we had a duplex scan in PACU right after surgery in the recovery room. And then we did another duplex scan on day 2. And we wanted to see really what was happening. And without showing you all the data, this is all published data we did, but you can see there was a slight advantage. The problem is the numbers are very small. There was a slight advantage by giving preoperative heparin in patients as opposed to postoperative heparin in terms of DVT formation. Some of the other things that we found was that there was no difference, however, in overall DVT rate, post-op DVT, or bleeding complications. So this issue regarding give pre-op heparin is actually not correct. It's okay to give that if you decide to do it. Most of us, I would recommend, based on our data, even though it's not 100% diagnostic, 100% robust, is to give it pre-op. But what's very interesting is that 4% of the patients who came into surgery in PACU, pre-op, had a clot. They walk in with a clot. And yet, so the question is, what does that mean? Well, CMS penalizes you now if you develop a DVT in the post-op setting. So is that fair? The patient walked in with a clot. So what we're recommending, particularly in high-risk patients, i.e. IBD patients, that these patients have pre-op duplex scanning. And if there is evidence of a clot, either cancel the surgery or potentially just screen them much more often, like do a duplex right after surgery, make sure they don't extend, et cetera. What about perioperative steroid dosing? Steroid withdrawal, okay? We're all worried about this. Stress dose steroids have been the standard of care forever. I shouldn't say forever, for at least 60 years. They're thought to be necessary in patients on steroids at surgery. This is what I was taught when I was young. And every patient was off steroids, but had any prior exposure within the past 12 months. But if you look back at the data, where does this come from? This comes from 2 case reports in the 1950s that said you're supposed to get steroid stress dose. And there's little objective evidence. So what did we do? We did a randomized trial. Okay, we compared patients who had low-dose steroid to high-dose steroid. And what we did is everyone who came in, they were randomly assigned to whatever dose of steroid they were on at the time, just a dose equivalent, okay, or they got stress dose. And we compared what, in fact, the difference is. And I think any genius can look at this and say there was absolutely no difference whatsoever between the patients who got low-dose steroids or high-dose steroids. There is no value for stress dose steroids. And if we look at even some of our secondary outcome measures, okay, let me just look here. These are some of like postoperative orthostatic hypotension, any orthostatic hypotension. That was actually our primary endpoint is any hemodynamics instability. But you see there's absolutely no difference whatsoever. But yet even when you look at our secondary outcome measures, stole cold the same. So there's absolutely no role for stress dose steroids. You give whatever dose the patient is on. If you had a patient on steroids who was on them for 9 years and somehow or another got off them in the past month, okay, and then they need major abdominal surgery, there is no role to give steroids in that patient. Okay, that's what I would recommend in your patients. And what about this? This is another complication that we sometimes see. There's a very interesting complication related to ileal pouch surgery. It's a portal vein thrombosis. And usually what happens is that the patient goes home and they come back with some nonspecific abdominal pain, and you can see by my green arrow here, they come back into the ER, and everyone and their mother who comes to the ER gets a CAT scan, and this gets picked up, okay? And the reason that this is fairly common in ileal pouch surgery is that it not only arises from the IBD hypercoagulable state, but because, as Feza told you, sometimes there are tension issues in the operating room. As we're pulling down and trying to get this pouch into the pelvis, sometimes the superior mesenteric vein, some of the draining veins get squeezed narrow. And when they get squeezed down narrow, they can potentially have less blood flow. The good news is that there's no long-term consequences to bowel function. It's rarely necessary to even treat them, unless they're symptomatic. The problem, as I mentioned, some of the patients come back with nonspecific symptoms. You don't think it's actually related to the clot, but you're kind of almost forced to actually treat them because in case something happens, you're basically doing a CYA factor at that point. Okay, that's what I want to talk about. Thank you.